Hello and welcome everyone. Thanks for everyone for coming. It's now 10 o'clock on the 10th of November and do we have any apologies?
Good morning, Chair. I've received apologies from Councillor Bentley, Adams, Jones, Mansfield and Statham.
Okay, thank you. And do we have any declarations?
I just want to make you aware of that. Right. Good morning, Chair and everybody. Sorry if I was late. I was in another meeting. Yeah, I do have a declaration. I'd like to actually declare that I am actually an ambulance driver and part of an ambulance crew. So I will not be taking part in any discussions about the ambulance service.
Okay, thanks for that. Do we approve the minutes held on the 15th of September 2025? Yes. Okay, thank you. Now I'd like to introduce our first speakers. It's the West Midlands Ambulance Service on the performance, and it's a report of the West Midlands Ambulance Service. Okay, and I'd like to hand over to them.
Should we do some introductions just so committee knows who we are? So good morning, everybody. I know one or two faces around the table. I think there's one or two, but a lot of new faces too. So I'm Vivek, Strategy and Engagement Director with the Ambulance Service. I'll ask Jez to introduce himself.
Yeah, very good morning, all. I'm Jeremy Brown. I am the director that's responsible for the control rooms, but with a specific strategic lead with the Staffordshire ICB and the system.
And good morning. I'm Murray McGregor. I'm the comms director for the Trust.
So I thought there's a lot of new faces, so we'll perhaps just give an overview of where we're up to as an organisation, then we'll also talk obviously more specifically in the Staffordshire context as well. So it's been a while since we were last here, perhaps more than a year I think. So when we were last here I'd reported that our response times had considerably improved from where they had been previously. That was clearly a good thing. So the main headline target we're responsible for achieving is what's known as Category 2 response times. That represents about 2/3 of our emergency workload. So Category 2 calls are things like strokes and heart attacks and things like that. So last year we just got under the 30-minute threshold. So the national standard is 30 minutes and we delivered 29 minutes and some seconds. I'm pleased to say to the committee we've managed to sustain that during this year and have improved it since. So the target that we've been given by NHS England is for us to deliver 28 minutes. At the minute we're at 23 minutes year to date. However, I'll come on to why that's under some pressure now, because the actual time we've have been gaining is now beginning to erode as we get into what isn't actually winter but kind of is, and we'll talk a little bit more about that. How did that happen though? Because if we go back in time, so we've gone from 36 minutes to 29 and a bit, and currently as I say, better than that. That's against what has been a rising tide of handover delays. So we do have what are actually the worst handover delays in the country by some margin. I had to write a little list out because if our handover delays equal that of North East Ambulance Service, South Central Ambulance Service, South East Coast Ambulance Service, North West and London Ambulance Service added together. There's only 10 ambulance services in the country. So it's pretty pretty bad. Now, how have we mitigated that? Well, we've put in a huge amount of additional resources. So we've put in, over the last 18 months, what amounts to something like £30 million worth of additional frontline resource to offset the time that ambulances are spent in hospitals. Anything we can realistically do that's in our control. Last year, we were supported in doing so through a mixture of financial support from the centre and also from our ICBs as well. This year have been supported to an extent from our ICBs, not by the centre, but through the 6 integrated care boards, but not to the full extent of how much it's costing us. The reason we did that, because if some colleagues may remember, I think when we were last here, we had not long before our CQC report, and we were given a regulation, what's called a Regulation 12 notice, which is a patient safety notice around response times, and the requirement of us was to deliver 30 minutes or better. So we had to do that. That's a legally enforceable compliance action from the CQC, so clearly we had to do that. So October, the reason why I talked about 23 minutes, well, 3 months ago it was 21 minutes. We've been losing a minute on our year-to-date performance every month at the minute. Sorry, it's not good use of language, is it? Too many minutes I'm talking about. Why? Well, the amount of time ambulances are spending at hospital is rising and rising. So for October, it's 41,000 hours. The month before that, it was 31, and I think the month before that, 20. So we're on quite a steep curve there. So clearly, it's quite a difficult period, not just in terms of performance, but of course what that means to patients, what that means to our staff. Because whilst we may be still getting to patients in a reasonable time frame most of the time, that doesn't help the patient who's then stuck in an ambulance for 5 hours or 10 hours or 15 hours outside the hospital, maybe being moved around 4 times between ambulances outside the hospital. That's not a good experience at all for them. Now, coming back to more local sort of briefing and information, the Staffordshire and Stoke-on-Trent system for us is amongst the most pressurised in that regard. So out of those 41,000 or so lost hours in October, 8.5 of those are in Staffordshire and Stoke-on-Trent, and primarily at RSUH. The NHS in its planning guidance earlier, when it was released earlier in the year, mandated all hospitals to deliver a maximum handover wait of 45 minutes. That is not occurring here. It's not occurring anywhere in the West Midlands, perhaps with the exception, I might say, of South Warwickshire, actually, who actually managed to maintain that standard most of the time, to be fair. Here, what does that mean? Well, perhaps 2,200 patients didn't meet that standard in October alone. So we go every month with thousands of patients not being handed over in the time that government and the NHS requires us to do. That as a scale, I guess, what does it mean? It's lots of numbers, but there's, the amount of this is a problem is probably equal to what goes on in the entire North East. So it's a really difficult issue that we grapple with alongside partners. What I might do then, if I may, is just share the slides. That's a bit of sort of preliminary briefing. If I just go through the slides, I'll just share my screen. Hopefully the technology will work. Where are we share? Right, working. So I've provided a bit of information here, just data, and we'll obviously talk around it in terms of what's going on here. So this is Staffordshire and Stoke-on-Trent. We share this with our partners. This is information that our partners receive off us every month, but I thought it was helpful to bring it to the HOSC. So what does this tell us? So what this is telling us here is the long-term trend of the numbers of ambulances going into hospital is reducing, and that's reflected by the red bars there. So that's the actual patients going into hospital by us. What it doesn't describe, though, is how many patients self-present to the hospitals. So whilst we may be bringing in fewer, they may well be having more patients arriving, through their own means. The blue bars represent the individual calls we get. So the numbers of calls we get do not actually reflect the individual patients we deal with, because clearly if you, for example, have a big car accident, there could be 15 phone calls for essentially the same incident. So the blue bars represent the individual patients we deal with. Now, that's the one thing our partners ask of us, because the one thing we can do to help everybody is to take fewer patients in to the emergency departments by ambulance. And I have to say, in Stoke-on-Trent, whilst I talked about some really difficult stuff, and Staffordshire, we are really, really well served by the alternative pathways and single point of access that we've got here. Across, if I was to compare Staffordshire and Stoke-on-Trent to the other 5 ICBs, we put by far the most patients through alternative pathways of all areas here. We are very well served in that regard. I'm very grateful for it. This is the current situation around lost hours. So the green, if you can see it, is the current position. You can see October there. So this year is worse than last year. And last year wasn't acceptable or remotely good enough either. So we are in a really difficult position. What does this mean? Well, you will see the local media and press like we do. You know, this means 20, 25, sometimes 30 ambulances held at a hospital, not for 5 minutes or 10 minutes, but for hours on end. We might have at peak 60 crews covering Stoke-on-Trent on Staffordshire. So when half of them are at hospital for hours on end, you can clearly see the effect that has on response times. There isn't like a magic tree that just releases, you know, puts more and more ambulances onto the road. It's a finite resource that's there. And then this slide here, sometimes the NHS talks about activity and demand being an issue. In our context, we don't go anywhere talking about demand being our problem, because it's not. We're not overwhelmed with activity. So the green line represents the numbers of patients going into hospital. The blue bars represent the lost hours to handover delays. Stretching back, I think, to 2019-20, so it's a long-term view. Our demand curve is where it's always been, and if anything, a little bit below, actually. So we don't have a demand side issue that we need to talk to anybody about. As I say, that may be different to other partners. As I say, for example, self-presenting patients may be a real issue. But I guess the point here is we're not, I don't think, overloading the system with lots and lots of more patients turning up by ambulance and contributing to the congestion is what this feels like it tells us. And then we've got 3 slides here. So this represents the 3 response standards we have. So category 1, category 2, and we'll come to category 3 as well. So category 1 patients represent the sickest of all. So that's people who were in cardiac arrest, fitting children, the most seriously unwell. And you can see, so the response times are the average and the 90th centile going across in terms of the red and the green. And the blue represents the handover delays and the lost hours associated with it. And you can see the relationship there. Now, category 1 calls are challenging, because we actually, thankfully and mercifully, don't get so many. We might get, maybe Jez, 150, 200 a day?
Yeah, so we roughly represent 11% of the activity. It's a Cat 1 out of the whole bucket of incidents that we deal with. About 11% are Cat 1s.
So would that be out of, say, 4,000 calls?
Yeah.
Oh, sorry, I keep forgetting. Category 2, which is where the bulk of our workload is, as I said, more than 2/3 of it, and also represents quite a diverse range of patients, because what you could have is actually some really sick people in this cohort, and actually with the way the assessing works nationally, it's not our local determination, maybe some who are less so. It's a big catch-all of people. Well, you can see what was happening previously when our handover delays were modest on the left-hand side. You can see what then happened as the handover delays took off. Then you can broadly see when we started to put in the additional resources behind it, what we managed to achieve with the response times and how they were improved. So they didn't keep tracking the lost hours. But whilst at one level we're pleased with that, it's not sustainable. It's not sustainable for the NHS to keep pouring in millions of pounds behind lost hours, because actually it's not a good use of money. The resources are out there. We're not saying we haven't got them, but they're just not in the right place, are they? They're not responding to patients, is the issue. And then that should be, so that's category 3. So this is typically sort of fallers, slips and trips, less urgent. It's urgent, not emergency. Now these patients can wait a protracted period. We've improved it. It's not actually till the standard yet. We do need to do more in this area for sure. But as you can see again, that's our average and the 90th centile wait time. As I said, we're really well served actually by our community partners in the community in terms of alternative pathways. We get, for example, we get far more patients through alternative pathways in Staffordshire and Stoke-on-Trent than we would do in Birmingham, and that's despite having quite a considerably larger population base there. So you can see that, you know, we are really well served. I think UH&M would absolutely recognise the problem that they've got. They wouldn't deny it, or they wouldn't say we don't have one or try and dodge that. They wouldn't. They are very honest about that. We do have good relationships and partnerships in place between us all as health and care partners. We ourselves are just trying to focus on the things that we can control, which is our resourcing levels. How much resources are we putting out there, and what are we doing with the opportunities to avoid ambulances going to hospital? But I guess as a final point, clearly there is an urgent need to still recover the UEC pathway because it is nowhere near good enough for patients or staff. It does need to improve considerably. And then final slide here. I didn't put this in the pack at the beginning. I should have done, and I'll send this to Zach so it can be circulated to members. But this is the lost hours by Integrated Care Board by month. So you can see. So I guess Staffordshire and Stoke-on-Trent, you know, it's not the same population base as say Birmingham or Black Country. Birmingham and the Black Country, sorry, individually around 1 million to 1.2 million population. I guess Staffordshire, Stoke-on-Trent, I'm guessing is around 800,000 or so, give or take. But that's just for your information, and as a comparison, I can send this to Zach so we can circulate it to committee members. And I'll perhaps stop there, and obviously happy to take any questions or comments or queries if I may. Thank you, Chair.
I'd like to pass you over to my Vice Chair, Charlotte Kelly, first, before everyone asks their questions, as she's got some burning questions to ask.
So I was looking through the report from last year. It seems to be that there was some actions that were to be taken by the ambulance service. The first of which was this report. It was requested last time in the last committee that you add extra information onto the report, not just give graphs. That we seem to have just received the same thing again. As well as this, in the final report, the committee requested that there was a winter plan to build up resources, and that was to be phased throughout the year as well. Just wondering how that's going. I was just going to do the big low from what was said previously in the last year, and then if you can respond to everything. As well as that, it was said that you had signed up to an agreement at the beginning of October 2024 where you were adopting models that paid no patient in an ambulance waiting longer than 45 minutes. This was something that you said that you were adopting, not the ICB, but this was something you were doing. And as well as that, the committee requested to receive a breakdown of performances within Staffordshire as well, which we don't seem to have gotten, but this was what the previous committee requested. That's it. Thank you.
Okay, so we'll take them in turn. I guess happy to be guided as to what information you do want. So if the committee was to let Zach know what it is you'd like to see, very happy to provide that for sure. Let me just carry on through the other questions, if I may. Around the resources, so we have absolutely been layering in resource after resource, and as I say, to that, a full year effect to that is not far off 30 million quid's worth. So we peak now at around about 400 crews on duty, give or take 405, 397, isn't that, you know, of that nature. Without that additional resource, it'd be more like 340, 350. So there's around 50 to 60 more ambulances in the region at peak. That's also sustained over a 7-day period. So it's not like we have all these ambulances Monday to Friday. It'll be the same peak on Saturday and the same on Sunday. So it's no different. This year, our final cohort of paramedics are coming out in December in line with our winter plan. So that layering of additional resources is absolutely what has happened. Around the 45-minute comment, that wasn't something, that's not for that's not just the ambulance service to do in isolation. That's national policy from NHS England. It was in the planning guidance for acute trust to implement. 45 minutes is a maximum wait, but actually 15 minutes has been the routine. Other parts of the NHS in the country have managed to do it largely. So London, for example, I think South Central. It's beginning to be adopted in the Southwest as well. From April to September, from memory, we've had 75,000 patients wait over 45 minutes in the West Midlands. It is not happening here for a variety of reasons, but it's not happening across the West Midlands, and it's not happening in Staffordshire and Stoke-on-Trent. But as I say, that wasn't something we were going to do. That's national policy. Around performance, I'm pretty sure we gave a breakdown of performance by postcode in the last HOSC. I think we did. Forgive me if we didn't. If that's something that's wanted again, that was a specific ask I remember in the last HOSC, but if it's wanted again as a matter of routine, we can absolutely do that. It's not an issue.
Have any follow-up questions?
No, thank you. Just how are you working towards the 45-minute wait times? I mean, if you're saying that you're not meeting it and that there's a number of reasons why not, how are you working if it is national policy and that is something you need to be getting to? How are you working towards it?
If I can respond to that, if that's okay. The 45 minutes is one of those areas that is almost the responsibility of our partners. It's not something that we can control ourselves. The only thing that we can control is the flow of patients into ED. And actually what we can demonstrate is that if you look at demand activity being 100%, we're actually only conveying about 46% of that 100% into ED because we're using alternative pathways. We've got an improved clinical model within our control rooms where we've got advanced nurses, paramedics that are advising and supporting patients remotely, eradicating the need to respond in the first instance. And we've also got pretty much on a 100% basis that there is a paramedic on every vehicle, on every ambulance, the way that we work. So they're able to do an awful lot more at the scene with a patient, so we're not conveying patients unnecessarily. But the 45 minutes is something that is being tasked to the acute hospitals directly, in conjunction with NHS England at the regional level and the ICBs. We can only control what we take into the hospital. You know, we could take a stance like in other areas that they may have done that, where we're almost pushing patients through the door and then walking away. But I don't think that really does offer patient benefits, and it creates a different level of risk that at this moment in time, that's not something that we are doing.
Thank you. Councillor Norman.
Thank you, Chair. Can I just say, first of all, that when I first became a councillor way back, spending £76,000 was weighed heavily on my mind. A few years later, I was voting for £1 million here or £1 million there, no problem at all. But what I wouldn't want is your responsibility, because you know I real feel for you and the difficulties that you have and the strains you have. So I just want to say that as context. We've also let you know we had the Health Watch reports, which are giving us some context to the issues you face on that, and I appreciate that, Chair. Particularly the virtual wards and that, which we may come on to at a later stage, which obviously goes back to affect the hospital and waiting times and so on. I've just got a couple of questions at this stage, though, if I may. One is, I'd assume chest pains was a Category 1 category, but it's how you categorise them. So for anybody ringing up, and I've had to do this a few times with family of late, you ring up and it's obviously 999 because it's a serious thing, chest pains, not for me, but for others. Then at the other end, that's where the category becomes 1 or 2 or whatever. And instead of it being, you know, there's so many minutes, it's actually, well, make your own way to the hospital the number of times, or it's going to be so many hours, that thing. The other question, because it's not a difficult question, is on graph 2, is there's a jump. We've got the graphs there, but there seems to be a jump in August and September, and I just wondered if you knew why that was. Presumably each August or September. I can have guesses, but I don't know what that is. So if that's okay, there's 2 questions. There's obviously if you can put everything in category 2, and it'll help you. But I assume that there's the process of making sure that it's a Category 1 or not a Category 1 is very robust and all the rest of it. Thank you, Chair.
Thank you, Chair. So ultimately, we are guided by a triage software called NHS Pathways. So there are 2 different triage softwares that exist across the country in the ambulance sector, one of which is NHS Pathways, which is what we utilise. It's a nationally recognised triage system endorsed by NHS England, with it being NHS Pathways. It is their own product, and essentially we have non-clinical call takers that are highly trained in processing 999 calls. They follow a set of algorithms that are purely based upon the answers that are provided by a caller or a patient, and then that determines the categorization of the call. So it's not down to chance, it's all done through some very complex algorithms. And just for noting, a chest pain isn't a Category 1 call, that's a Category 2. So Category 1 calls are pretty much reserved to patients that are in a state where they are either unconscious with noisy breathing or in a confirmed cardiac arrest or actively fitting. So these are cases where you're talking seconds rather than minutes if we're not there to be able to provide life-saving support and assistance. Category 2 are still life-threatening emergencies that should get a response within 18 minutes, although NHS England have put in a stretch target of 30 minutes, of which we are achieving 23 at the moment. So we're ahead of that curveball, and actually, in comparison to the rest of the country, we're pretty much up there, 1 or 2. So we are doing a decent job, but although that's not to move away from the fact that the target is still 18 minutes for a Category 2 response, and they are things like cardiac chest pains, strokes, unconscious patients that are confirmed as breathing, those kind of things. Does that answer that question?
And then you had a second one.
Well, yeah, from my experience, it's been hours, or make your own way with chest pain. So I don't understand that from personal experience, but be careful with anecdotes. Now, the second one was about the second graph, where there's a jump between August and September this year and last year. I just wondered what the reason. It's not your fault, I'm sure. What the reason is that you presumably have more calls or whatever.
So the activity increases realistically are, we're quite a unique ambulance service really, being landlocked. So we're a mass exporter in the school holidays, or exporter. So most people go away on holiday. We don't see any great demand jumps like you might see if you were the South West Ambulance Service responsible for Devon and Cornwall as an example. But what happens as soon as the children go back to school is that all of the prevalence of coughs, colds, DMVs, other kind of illnesses start to become more prevalent, and we do see our activity jump then. But it really is, the demand does tend to drop within that August period.
Chair, I just assume that's not personal attack on the tourist aspects of Staffordshire, or indeed the districts within it. So, I'm sure that's just explaining what it is. It's not a criticism there, tourism in Staffordshire.
Councillor Norman, can we please keep it to the questions? Thank you. Councillor Edgeler, thank you.
Thank you very much, Chairman. Good morning, everybody, and thank you for your presentation. I've sat in this meeting for many years and I've listened to the same arguments really regarding the ambulance service and waiting times, and they don't seem to be getting any better over the years as we go on. Correct me, please, if I'm wrong. But I look at UHNM and the problems that the wait times that I have there. What is your opinion if County Hospital was open, and would that help the situation? That's my first question, really. And the second question is, where do community first responders fit into all this, and what help are they giving? And what's your thoughts on, more input from those people? And, listening to all the problems and everything, I really throw the question back at yourself and say to you, what do you feel would help you in the situation you're in? What do you feel would be the answer to the problems that you've got? Thank you, Chair.
I'll perhaps pick up on the first one. Would it help us greatly, or to a significant extent, if county hospital was to open overnight, for example? I don't think so, because whilst, in principle it might seem like it could help in terms of another location and another exit route, those services have to be clinically sustainable and safe. To have a rota, if you look at, my background's in hospitals before the ambulance service, in a specialty, you need to have to have a consultant on call rota requires a whole establishment of consultants and junior doctors and everything else. To underpin that, you then need a level of activity for them to be sustained in terms of the case mix they need to be working with. And overnight, to sustain things like trauma, surgery, and medicine is there, of course, just wouldn't, it's not clinically sustainable and therefore not also financially sustainable. So if County was a much bigger hospital and had a much bigger population, it could sustain those sorts of clinical services, I would have thought. But that's not actually the case. Perhaps Jez and Murray might comment around CFRs.
Yep, so CFRs absolutely have a place, and we've got a good network of CFRs, but they don't count towards performance. The reporting, from a reporting perspective now, it looks very, very different. They will support Category 1 responses, but all of those other categories, because the way that NHS England now dictate that performance is captured, it's about having a clinical presence at the scene, somebody that's capable of conveying a patient, i.e. an ambulance. So from a performance point of view, not necessarily going to get any great gains from CFRs, although they're good for patients, and we are very much engaged within that community network and the CFRs. And your last question, if I may, Councillor, I think ultimately we just want our ambulances back. That's what we want. We just want to be able to hand the patient over and free those crews up within the allotted time frame to achieve the 45 minutes. NHS England have calculated with a maximum 45 minutes that the average handover time would need to be no more than 16 minutes, and that's what we need. We just need our ambulances back to be able to respond to patients. That's the difference. We don't need to then keep putting additional hours on the road, because in a way we become a little bit inefficient because of the amount of time that we're spending at the hospitals. Essentially what we really need is to get back to a model where we can forecast our staffing levels based upon demand rather than the hospital handover delays we think we might get.
Thank you, and I fully understand where you're coming from on that. Would it help if such as UHN, I can't even say it, had got like Nightingale places like they had when we had COVID, so you could actually put the patients into there and release your ambulance service? Thank you.
There is a sweet spot for how many beds a hospital should have. If you open up too many beds without the right level of stuffing behind it, you become less efficient actually. Have too few beds, and again, you get huge inefficiency. So there is a sweet spot actually in a bed base. So just opening up more and more beds isn't necessarily the answer, because those more and more beds need all of the nurses, all of the therapists, the consultants, and everything behind them. Those new people don't exist, do they? So you'd be stretching your existing workforce to cover more and more beds, and that would make a hospital less efficient than it already is actually. But whether they've got the right bed base, I don't know. That's a question they would have to ask, because as I say, there's a sweet spot, and whether they've got the right number, we don't know. They need to ask that. But just opening more and more isn't necessarily a solution here either, I'm afraid, is my view. Thank you.
Thank you. Councillor Brown.
Good morning, Chair. Thank you very much. Good morning, everybody, and thank you very much for coming this morning. 37 years in the NHS gives me quite a background to all this. I completely understand most of what's going on. I've also got a bit of an insight in what's going on as well. I'm very concerned that the first 4 minutes in a cardiac arrest is crucial. And did you say 23 minutes is currently response time for a Category 1?
No. Our current Category 1 response time is 7 minutes 59.
Okay, beg your pardon for that. So thanks for that. So I think it's really important that people understand that 4 minutes is crucial for a cardiac arrest, isn't it? Another thing I'd just like to bring in is the fact that these lost hours, so was it 41,000 lost hours last year? For October. 41,000 hours for October. Okay. So that means, does everybody realise this is the time when the ambulances are stood outside an A&E or emergency department? So, for instance, on social media, Burton Hospital, Queen's Hospital Burton, currently, was it on Friday, had a huge, huge queue, and people were already saying before winter beds. And also, I just want to ask, let's be more positive about this, a way forward. is there and obviously Councillor Edgley's obviously already touched on this, but I think this is really important. Is there a steering group, or is there something manageable and positive that you are able to work with emergency departments? And it's not just happening in Stoke-on-Trent and University Hospital North Midlands. I'm really concerned that there's an awful lot of people who understand what's going on, and their knowledge and ideas are not being used. Their insight is not being used. Your insight's not being used. And there really should be a collaborative approach to looking at this, and hospitals not being isolated in looking into this. I heard what you said about opening up Stafford County Hospital, but possibly there might be a different triage system where you might be able to take patients to a lower grade. If it's just to go and see a doctor because they've got a low-grade chest infection, they're an elderly person that they wanted to keep at home. So obviously I've got probably too much to say now, so I'll let you talk. But I think we need to be positive, and we need to ask questions, and we need to ask for action. And there's a lot of people, including myself, who would like to work on this and move forward with yourselves, and obviously the ICB and the trusts in question. Thank you for listening.
Thank you. They're really great points. I mean, what I can say, as Vivek has already alluded to, there's an awful lot of collaborative work that's taking place at the moment. We work very closely with the ICBs, with the acute hospitals, and there is recognition that some of the issues that we are facing, some of the challenges that we are dealing with, are almost of the acute to try and resolve. Some of it is about the flow within the hospital itself, rather than having huge amounts of requirements for additional capacity elsewhere. A lot of it is the flow within the hospital, because the one thing I will say is that almost each and every day, every one of those patients that we see that's parked outside of the hospital does eventually get in. So it's not like we're suddenly seeing that the doors close and we're getting turned away and having to go somewhere else. So some of it is about how that flow is managed within the hospital site. But there are a number of different work streams that are in existence that are working very closely together to try and resolve it. And Royal Stoke are also currently being supported by NHS England directly. There is a team that are in place at the moment to try and work with them to resolve some of those issues. And actually, he says with his hand on board, we've had a far better weekend than we've seen of late, with a minimal amount of delays, and things are starting to look like they're going in the right direction.
I totally hear what you're saying, and I understand everything you've said. But I still feel that there is a point that's being missed. I do feel that there's valued members of staff on the ground who know what's happening. It is partly about flow of patients through a hospital, but I think there's other things going on, and it's great to hear what you're saying, but I think there needs to be a far more dynamic review of this. And I actually think a staff survey to come up with ideas of how things can be changed. But we all know what's going on. We've all got ideas of what could be, but I'm not sure if everyone's listening, and I think that's something that you could take forward, please. Thank you.
Just something that's just come to mind, actually. One of the things that we've asked for, and is in trains, it's kind of along the lines of what you're asking for, is for the systems leadership, so Acute Trust, ICB and other partners, to actually hold an open session for staff to talk about winter plan and how we're going to get through, and what our response is to this. So our own staff have been, particularly in this part of the world, in Stoke-on-Trent and Staffordshire, getting increasingly concerned and anxious about what's to come. So we agreed actually that the leadership in the system should basically provide a briefing session to staff, and it's open to all staff, so ours, Acute Trust, mental health community, everybody, for them to hear directly, and also for them to ask questions and perhaps offer solutions as well. So we've got something in train around staff being briefed directly, so operational on the on staff on the ground, so to speak, to have that opportunity to listen to what's going on around them in terms of planning and response, but also for them to have the opportunity to ask questions and contribute. That's something that's in train now, actually. Thank you.
If I'm just very, very quickly, briefly, thank you, Chair. Just to say that's fantastic, but I do think there needs to be a slight anonymity about things as well. There's staff on the ground who really know what's happening, come out with ideas, and sometimes are not willing to speak up, even though there's fantastic whistleblowing policies and all sorts of that thing. But thanks very much. Thank you, Chair.
Just quickly, obviously we've seen that you've explained the wait times and the wasted hours, ambulances waiting outside, the fact that there are other hospitals. What if, as a suggestion, what if, and why wouldn't it be okay if you could, it's more a question and a statement, if you know that there are ambulances waiting outside Stoke, and you have someone in the ambulance that possibly necessarily wouldn't actually need Stoke, what if the ambulances were directed to other hospitals? Do you do that, or is that already sort of, is that something that you're thinking of doing?
We do that, we did that, but what that does do then is it adds some complexities about then that patient then needing to be reunited or then managed onwardly. But we will actively move patients around, certainly at the hospital's request. You know, Burton, the relationship between Burton, County, Royal Stoke is pretty solid, and we will move patients around those areas. We did have it very, very open a couple of years ago that caused an awful lot of additional issues or challenges where we would literally flow into any hospital that had capacity. But of course, then those hospitals that are performing well, that are managing their own patient flow within their own ICB areas, start to almost question what's happening, why are you bringing all these patients here? You know, we forecast to look after our own footprint rather than being able to then accommodate everybody else's. So it does happen, but not to the degree where it is so flexible, a bit like choosing a supermarket. If you know that Sainsbury's is going to be busy tonight, you could choose to go to Morrison's. It's not quite as flexible as that.
Okay, thank you. Councillor Wallins.
Thank you, Chair, and good morning, everyone. I do have quite a few questions, so sorry if I'm taking up a lot of time here, but, you know, it's best to ask questions, I suppose, in a scrutiny meeting. Which hospitals in Staffordshire are worst performing when it comes to the handover delays, and what measures are in place to improve these delays and so forth?
So there aren't that many hospitals in Staffordshire, and by a long margin it's RSUH who struggles the most with the handover delay situation.
So, I mean Staffordshire, West Midlands as a whole, like Good Hope and so forth. Sorry.
So sorry, I beg your pardon. So if there was a sort of league table, the UHB group in Birmingham would have more lost hours than Staffordshire and Stoke-on-Trent. But then it's a bigger population and more hospitals. If you looked at individual sites, then RSUH and Birmingham Heartlands Hospital are pretty close, sort of neck and neck when it comes to lost hours. So Birmingham Heartlands and Royal Stoke are right up there.
Thank you. And the next question is about the lost ambulance hours and so forth. What is the estimated cost to the taxpayer for lost ambulance hours?
For last financial year, it was something to the tune of 30 million. And this financial year, we're tracking above where we were last year, so conceivably the cost could be higher.
Thank you. And I was wondering, what is the NHS doing to work with third-party providers to potentially cut down the waste for the ambulance hours and so forth? So, for example, these obviously a third-party service to take patients to hospital. Is there waiting for like a 7 or 8 hour for an ambulance?
So who would those third parties be, sorry?
Well, any third party at all, like for example, yeah, so like any like charitable service providers and so forth. Is the ones I could think of off the top of my head.
So there are other forms of ambulance provision out there, private ambulance providers, for example. They do exist. There's other forms of ambulance provision. I guess, but if there's, we're already spending money we don't have on our existing provision, and if there was more resource that could be made available, we'd invest it in ourselves to put more ourselves out there. So we don't struggle, thankfully, to recruit. You know, we can recruit to whatever we conceivably have the resources to spend. But if we were to spend more money on more capacity, we would do that ourselves. But we, as I say, we're currently meeting our standards, but also the bit we're also pushing people very hard, and we don't want to be spending more money because it's actually throwing good money after bad, actually. We're at pains to say this at every opportunity that we can, that we don't want to be spending 20 and 30 million more on ambulances for them to just be held outside. It's not a good use of resources at all. So whilst it was an imperative to do that, because if we did nothing, our response times for category 2 would be closer to 50 minutes than they are at 23, which would be a wholly unacceptable situation to be in. So we had to do something. But just continuing to put more ambulances on the road against more and more delays is not where we want to be, because it'll be never ending and the taxpayer can't afford that. And nor should it if its resources are already out there in the system. They just need to be used for the right reasons.
Thank you. And the last question I want to ask is, how many staff does the NHS have for, when the ambulances do the handovers, obviously for A&E and various other departments? Because I imagine a lot of these workers that work in the NHS obviously are probably subject to burnt out by doing, because it's more like 12-hour shifts, more or less. And to follow up on that, is there any reserve staff in place to compensate for example, if you're short on staff?
So we're not short on staff. We are very, very fortunate that, as Vivek had alluded to before, we have a strong recruitment strategy.
Can we please keep our conversations down, please, because we've got speakers in. Thank you.
Okay, so we have a strong recruitment strategy. We have really good, positive engagement with our own student paramedic program. So we don't have a problem with recruiting staff. From a resilience point of view, I guess we've got the fortunate position of being able to upskill some of our PTS staff. We can utilise those during winter precious periods if we needed to by providing some additional support. These are people that want to move on to A&E ops, that want to become student paramedics. We can support them in their journey in doing that. But we don't have a problem resourcing as such. From a burnout point of view, I think if I just speak about our own staff, so the paramedics, the technicians, and something I'm very personally close to because that's what I look after is the control room staff, there's an awful lot of pressure on those members of staff. Some of our paramedics can become de-skilled because they're spending so much time outside of the hospital. And actually, what they really want to do is be helping that next patient. They don't want to have to look after somebody in the back of an ambulance for a prolonged period of time. They are mindful that most of us, including myself, live within the areas that we work. So I had the pleasure of only having to travel a couple of miles to get to work this morning as opposed to going into Dudley, which is where I am normally based. So we are passionate about being able to respond and be able to deal with that next patient, and our crews are no different.
Thank you for that. Councillor Doherty.
Sorry.
Oh, sorry.
Sorry. Thank you, Chair. I think the other point to make is that our staff are really unhappy with it. It affects their home lives as much as anything. If you're working a 12-hour shift and you finish an hour, 2 hours late, it's a 14-hour day. We have to give them 11 hours off between shifts. So that actually has a knock-on effect if they're 2 hours late into the next day. So you can see how it's a real problem. Many of our staff are in their early 20s, early 30s. They've got children. They miss putting their kids to bed at night. And that is a real tragedy for them. So there's a moral injury for them as well because of the delays that they face.
I think to, I can feel where they're coming from and so forth, because I've never obviously worked in the healthcare sector and so forth, but I know from experiences doing professional driving as a living, obviously doing 12-hour stints and 16-hour shifts and so forth, yeah, it does take a toll on family life and your home life and so forth, but yeah, thank you.
Okay, thank you for that. Councillor Doherty.
Good morning. I would like to ask about efficiency and going back to a comment that Councillor Brown made earlier. In 2023, my husband had a cardiac arrest. say that. But 4 ambulances arrived. So my question is, looking at efficiency, and I know that obviously those calls go out to all drivers within a certain radius, don't they? Is there any way that that could be looked at so that the, like, because, you know, it was a little bit chaotic, I've got to admit, at that point. And to have 4 ambulances to 1 incident, then that's going to have a knock-on effect on other call-outs, is it not? Thank you.
Okay, so cardiac arrests are the most seriously ill of our patient groups that we respond to. And there is a minimum requirement to have 4 clinicians to be able to manage the scene of a cardiac arrest. Now, in the example that you've provided, and I do hope that your husband is okay. That's fantastic news. Essentially, we have specialist resources that operate across the footprint of the West Midlands, including within Staffordshire, that are enhanced coronary care practitioners. So essentially, they would be targeted to be able to provide additional drug support, drug therapy, carry different equipment to be able to manage a cardiac arrest. From an efficiency point of view, more in general, though, we're in a really positive place. So we do monitor what we call RPI, so essentially responses per incident, and we only send just over 1 resource on average to every single incident. That's why our model is very much geared towards having a paramedic on every ambulance. We don't over-resource incidents unnecessarily, we feel. And where there is examples that exist where we might send more than 1 resource to some incidents, some cases, then we can review that and then adopt our practices and our models to make sure that we are pulling that back so that we have got enough resources to be able to respond to that next patient.
And then a little bit more sort of broadly on efficiency. So Jez talked about the RPI is resources per incident. So, and another aspects of what we do incredibly efficient when we think about our estates, our fleet. You know, for example, we don't have any ambulances over the age of 5 years, so the amount of time ambulances spend off-road being repaired is minimal. There's all sorts of kind of proxies of efficiency. Where our productivity and efficiency is shocking, though, is on things like, for example, how many jobs does a crew go to in 12 hours? Because before COVID, so if you saw on those charts on the left-hand side, which is kind of just about pre-COVID, around then we were doing around 6.5, 7 jobs in 12 hours. Now I think it's around just under 3. And sometimes if your first patient takes you to hospital, it might be 1. And if you're sent to hospital to look after patients, you may not actually go to respond to a single patient. So there's a huge kind of efficiency, either upside or downside, depending on which way you look at it, if that problem was to be cracked. So in other aspects of what we can control, our efficiency and productivity, we feel to be in a strong place, but there is a massive drain at the minute, for sure. Thank you.
Follow-up questions? Councillor Kelly.
Thank you, and I'd like to say thank you to Zach as well for doing the work plan today, because I think after this we can then talk to the ICB about the other side of the changeover programme there, so I think that'll be great. So when you say, I've got one question and some follow-on, when you say category 2s are 23 minutes, is that an average or are they all below 23 minutes?
So that's the average figure. Then we also get measured at the 90th centile as well, but the NHS essentially measures the mean average figure.
You see, my area is Leek Rural, which involves areas of the Peak District National Park. So getting to places like Foxton, Moorslow, particularly in winter months, how is it that you're managing to do that? Because I know that emergency vehicles can't necessarily do that. So do you have 4x4 vehicles available? Are you utilising air ambulance? How are you getting to those places once they're cut off?
Yep, so we have a fleet of 4x4 ambulances that are strategically placed across our region, and Stoke won't be any different, and they will respond regularly into the moorlands. We have a good network of CFR coverage within the moorlands as well, which is positive. And absolutely, we have anything up to 5 air ambulances at our disposal at any one moment in time, weather conditions permitting, of course, but they will regularly go into the moorlands and respond.
Sorry, so what's roughly the response time when it is going to those places, where it is in the hills, where it is further away from Stoke Hospital? Because I know that we used to have an ambulance in Leek, and Councillor Jones isn't here, so I'll ask the question. There used to be an ambulance in Leek, and there used to be an ambulance station, so to get to those places in the hills where perhaps a 4x4 ambulance strategically placed right next to where it would need to go would be an option.
Yeah, I don't have the response times for specific areas to hand, but more than welcome to share those afterwards, as Vivek had already made that offer. But essentially, in order to try and make sure that we are best utilising where we need to be, we've got a model that is very much a hub and spoke model. We've got strategically placed ambulance hubs that will respond from a centralised point and move around the area. We have a system where no vehicles are ring-fenced to only operate within a certain area, so ambulances from all over the region, not just from all over Staffordshire, will be responded as required to meet the patient's needs. And from a moorland point of view, because of the model that we operate where we will respond actively on lower acuity cases, as we get cardiac arrests or category 1 calls, category 2 calls that then come in within those areas, ambulances will be diverted from those lower acuity calls to try and make sure that they meet the needs of those patients with the highest acuity.
Okay, thank you. Councillor Greatorex.
Thank you, Chairman. There's one question which is just a bit of a tidy up. I think it's a timing issue, that there's a conflict between what you said and what was on one of the slides, and it's about capacity. What you said today is the investment in capacity has brought certain results. But one of the slides said there's a loss of capacity. In fact, the slide actually says loss of capacity. Don't know if you know the slide, but I just wonder if it's a difference in timing as to why that's contradictory. But the main question I have is about the alternative pathways. They've been mentioned before, and the slide that really stands out for me is the one it's page 12 in our pack, but it's the one with the conveyancing rate. And the conveyancing rate shows quite significantly the number of ambulance journeys reducing, whilst the blue bars are showing the number of trips, the number of calls is on the increase. So the simple way of looking at that is that the reliance on the alternative pathways is quite significant and growing. So therefore my question is, and just to put it in perspective in numbers terms, you've got the dotted green line, which is the conveyancing rate showing on this chart from 2015-16 at 120,000 volume, down to, on the 2025-26, at the moment, looking like less than 50,000. So the decline in number of reliances on the ambulance service is over 50% in that time. That being the case, my question really is centred around the alternative options. And I'm not sure whether it's something you'll be able to answer, but given that there's such a significant reliance on other forms, what you're referring to as the alternative pathways, how are they handled? If we're talking about handover times, we're talking about handover times for what is a small proportion of the whole. If the other methods of delivery, and I'm assuming that they are voluntary services or people taking private cars or public transport, taxis, whatever it might be, how are they handled at the hospital? I'm not sure if that's a hospital question or whether you can answer it, but does that give a better service? Does it give a quicker handover? Does it therefore reflect on the way that the ambulance service delivery is going to be affected?
If I take the second part, or the second question that you have asked, if I answer that one, I think it's a great point, but essentially what we are seeing is that this slide is about transports to E&U. What we're actually doing is we're able, because we've upskilled a lot of our own staff, we're able to provide far more support remotely from the control room now. So clinicians that can engage with patients and signpost patients to go to pharmacies, back to their own GPs. We've got the ability to book patients in to see their own GP. We can book in with district nurse services, with community services. Essentially what we're doing is that this is the model that the NHS wants to strengthen. So these aren't volunteers as such, or any part of the voluntary sector in the main. We are referring to systems into different areas, into parts of the NHS still, that are geared towards being able to manage patients appropriately, but without having to transport or convey into that A&E or into that acute hospital setting. So this is almost by design. What we're demonstrating is that we are utilising those services that are being made available. And actually, as Vivek very kindly pointed out before, we've got such strong arrangements with the ICBs, with the system within Staffordshire, that actually we are probably seeing a far more productive amount of patients that are using those alternative pathways than in any other area across the West Midlands. And it is a positive thing, because a lot of the time when you go into the acute hospital, you know, you might be there for longer periods of time than you would be if you were seen in the community.
So, just on the resourcing thing and the capacity, I guess I'm not quite sure where the contradiction is in the pack, but we're in a bit of an arms race at the minute. So the arms race is resource depletion in terms of what's held at hospital, and versus us backfilling it and putting more ambulances on the road. It may have been a poor choice of words on my part in the pack, but essentially we've got an existing level of resources. A chunk of that stays at hospital in a 24-hour period. We're having to then layer in more on top in terms of capacity to mitigate that effect. So, as I said, if we did nothing, our response times would be plummeting right now. So it's essentially backfill. It's backfilling what's being held at hospital. But if I've not quite covered the point, then please come back to me and we'll try and explore it more.
If I can come back, it's our slide 14, and it's the one with a operational demand and handover delays title.
Yeah.
And it says the loss of 999 capacity that delays represent is substantial and is impacting upon communities.
Yeah, sorry. Yeah, so, well, I guess, so, sorry, that should say the loss of 999 capacity. So we've talked about 8,500 lost hours in Staffordshire, for example, and Stoke-on-Trent in October. It's considerably more than some other areas. It's considerably more than how the rest of the NHS is currently operating outside of the West Midlands. So if we think about if that resource was to be put back into play, would we need to be spending multiple millions more than we currently are? Could those things be spent on other things in the NHS? Yes. Yeah. Could our response times further improve? Because let's remember, if we go back in time, the actual standard for Category 2 calls was 18 minutes. The government moved it to 30. We used to be compliant with the 18-minute Category 2 standard. We're currently at 23 minutes. So we're still not where we used to be pre-COVID. So whilst we've backfilled it and we've made an impact and a difference, it's still, we would rather not be in this situation. We'd rather have our existing resources returned back to us and be more efficient with our resources. And then commissioning bodies wouldn't be having to put millions into us. They could be spending that on other things, because there's clearly not just our demand for what we need to do, but they're facing all sorts of demands for all sorts of services that are in need of investment as well.
Okay.
Thank you.
That's fine on that. Just to come back to Jeremy Brown's response, again, the page 12, incidents, transports and conveyance rate graph. I think what you're indicating is that the NHS is trying to drive people towards other pathways for resolution of the illness. But these, on the blue bars, are presumably 999 calls. Are you saying that there's that number of 999 calls that are deflected, if I can use that word, or passed towards pharmacies and other solutions that don't involve then going to hospital?
Yes, yeah, that's exactly what they're saying. Essentially, what you've got to remember is some of those calls will be duplicate calls, will be multiple calls for the same patient, but essentially we're able, because we've upskilled our own workforce and we've got other services that are available, all geared towards being able to signpost patients away from A&E, you know, huge initiatives about making sure that patients that are in care settings, so nursing homes, care homes, etc., don't go to A&E unnecessarily, that a lot of the time they're able to be treated at home, but care staff will still ring 999 because of the condition that they were faced with at that moment in time. But that's exactly what that detail is saying, yes.
Okay. I would like to see any information that you have on the alternative routes, though, in terms of other providers of transport.
Sure, more than happy to share that.
Okay, thank you, Councillor. Councillor Parton.
Good morning, everyone. Thanks for coming in. It's a good presentation. But my question is, pick-up times and treating on scenes. Do you know the times spent at people's homes, whether they treat them at home or they take them to the hospital? Do you know the pick-up times or the, from scene to the ambulance and to the hospital? That's my question, because some people get treated at home or at scene, i.e. if there's an accident or anything. Do you know the times that are wasted there?
So I guess what you're referring to is what we would call on-scene time. So how long is a crew with a patient? Now, for us, that's been getting longer and longer and longer. Why? Partly for the right reasons, actually, because what we've got, just going back to the previous conversation that we've just had, if you put yourself in the shoes of a crew now, you've got far more alternative pathways available to you. So that can take time to get hold of people. So whilst we do a lot of that alternative pathways directly from the control room before ambulances are dispatched, our staff, when they go to a patient, they've also got the access to all those same sorts of pathways too. So part of it is alternative pathways. Part of it, if we're being very honest, is you're going to fight very hard to try and get an alternative pathway for your patient if the alternative is a 10-hour stay outside the hospital. Because that's some of the choices they're having to face, aren't they? So if they can find an alternative pathway for a patient, they will try to, because the alternative may not be a great one. Now, so go back some years, actually the model is very much about respond quickly, get the patient to hospital quickly. It's much more complex now because the so-called easier patients to deal with have been filtered out by Jez's team already. What's now out there there aren't the easy so-called, they've already been dealt with actually, so there's much more complexity for them to be dealing with. The other thing we've also got that we all have to we all do acknowledge is that our demography is changing. We've got an aging population with far more complexity in terms of their care needs. They may not need acute hospital, but they may well need something from us. That can take time as well. So, in some ways we could become far more efficient if we just said, right, go to a patient, take to hospital. Go to patient, take to hospital. But that's not actually meeting the patient's needs necessarily. So we don't see it as wasted time in many ways. The other thing we just have to be careful of, we don't put our staff under any pressure to either leave at home or take to hospital, because we're not here to interfere in their clinical practice. Putting staff under pressure to make those sorts of decisions could start to, they could start to make some poor decisions on behalf of patients. We don't want that. We don't want them under pressure to either leave at home or take to hospital. It'd be the wrong thing for them. They're responsible for the care that they provide. They need to come up with the right decisions. But you're quite right to point it out, because it's an elongating time frame, because we're spending more time trying to find alternatives to the emergency department. Thank you.
Thank you very much. Thank you.
Councillor Adcock.
Yeah, thank you, Chair. My question's around an organisation that's calling itself Stoke Air Ambulance. Are you able to comment on any of the concerns that have been raised around this organisation? In particular, they've recently announced or claimed that they've secured a helicopter to put into use. Is West Midlands Ambulance Service planning to task them?
So the simple answer is no. So to task an air ambulance charity, they would have to meet all the regulatory requirements. They'd have to be CQC registered. They would have to have an airbase. They would have to have an aircraft. They would have to have the staff trained to the appropriate levels. As far as we know, they have none of those. We clearly already have 5 air ambulances available to us. We are the best served ambulance service in the country for air ambulances. There are 2 aircraft within easy reach of Stoke already. You could bring another one down from Cheshire if you really required another one to come from that direction. At the moment, both ourselves, UH&M, don't believe that there is any requirement to have another air ambulance in this region.
Thank you, Anne, and thanks for your answer, because I think you've answered my follow-up, because for context, this is an organisation that I'm sure you're aware is been under investigation for non-compliant fundraising practices and has caused significant concern amongst the local population. So my follow-up was going to be, do you believe there's any demand for an additional air ambulance service? I think you've already answered that. You believe there's no demand for such, despite claims to the otherwise.
I would agree with that, yes. There is no requirement for another air ambulance at this time, as far as we're aware, and certainly the hospital agree that there is no requirement for another air ambulance.
Okay, thank you. Councillor Vice Chair Kelly.
Sorry, I'm really not picking on you, I promise. All it is you may not have the details now. How many ambulances are cancelled because people are waiting so long that they decide to try and get themselves to hospital? And how are you managing risk if that happens? Say if a person broke their arm and was waiting 4 or 5 hours and just said, I'm just going to try myself.
Broadly speaking, it's about 10%. So 10% of our 999 call volume of patients that then confirm that they will, once they're aware of the delays that are likely in a response, that they will make their own way to hospital. And ultimately, that's a decision that they are making as individuals. The requirement to provide honest response times when somebody phones 999. So we operate within a model where essentially we have a business as usual, then various different levels of escalation. And in accordance to which of those levels of escalation we are depicts what advice a call taker gives when somebody phones 999. And essentially what we are doing is providing a narrative that says that it could take several hours before an ambulance is able to get to you at certain points within that surge, to enable patients to make or a caller to make a decision whether they feel that they need to make alternative arrangements and to convey to the hospital themselves. And this came about at the request of a number of coroners that we've attended, myself personally as well, where the families of people that have sadly passed away said that actually if they'd have only known that the ambulance was going to be a long time before it was able to respond, we could have done something differently.
Any follow-ups?
So if someone who says that they will then drive themselves, if they're not necessarily in a capacity where they should be driving themselves, does that then increase the importance of getting an ambulance there to them faster or not?
It's a difficult one, really, because the conversation that takes place is all around the ability to be able to go to the hospital. We're not asking people to do it that really shouldn't be. So, you know, if there's somebody that's taken an overdose or been involved in any kind of issue where there's alcohol involved, the advice is slightly different. That's not something that you're going to ask people to do. So I think what we're doing is in the best interest of providing a safe level of service, but it is about giving the information so that somebody can then make an informed decision themselves.
Okay, thank you. Councillor Wallins.
Thank you, Chair. I just have 2 furthermore questions to add on. How many calls do you receive that are incorrectly categorised due to human error? And what measures are in place to stop making when you go to categorise patients, to stop incorrectly categorising them and so forth?
So very few calls are incorrectly categorised. There is always an element of human error that exists, but in the main, we are very, very proactive in auditing our calls. So call takers are heavily audited. You could almost argue that they are the most scrutinised of any of the staff that work within the ambulance service. So a huge percentage of their calls are audited. Those audits are evaluated. Learning will be identified at an individual level or a global level if there's something that we need to do differently. But the numbers are very, very low. I'd say less than 1%.
Thank you. Any other question I just want to ask is, in the last quarter, how many ambulances are stuck with patients in the back at hospitals? Because I'd imagine it'll have a knock-on effect in terms of having ambulances on the road and so forth.
If we take Royal Stoke, in October there were 2,200 patients who waited over 45 minutes to be handed over. Their average handover time for the month was 2 hours and 5 minutes.
Thank you.
Thank you for that. Councillor Hood.
Sounds like I've got a crockery stall here, doesn't it? Thank you, Chairman. Just 2 points. The first one isn't a question. I was fortunate to be invited along with a committee group to go along to the call centre here in Stafford. Absolutely invaluable. And I know you're mega busy and you don't want people traipsing through there. But if any of you do get the opportunity and you're invited, please go. It's a real eye-opener. The second point, this is a criticism. So often we hear people here who give us percentages. Councillor Kelly just asked you how many ambulances are cancelled. You said 10%. Councillor Williams has just asked you a question. You said 1%. That means nothing to me, absolutely nothing. If you could try and answer the questions in numbers, that means far more to us. It's a bigger realisation to hear the actual number, the total, rather than hear percentages. Thank you, Chairman.
In relation to the first point that was made, thank you, Councillor. You are more than welcome to come and visit our control room, and we do have people that come and visit on quite a regular basis. It is indeed an eye-opener, but actually it gives a bit of context to a lot of what we're saying today and some of the real-life experiences, because you can sit with call takers, you can listen to them taking 999 calls, and you would be more than welcome, and you are very much welcome if you are interested in that to drop me a note, and then I can make those points and organise it. As for the percentages, no, absolutely fine. I'm sorry. That's my fault. That's the world that I almost live in, and it's a great point, and that's fine. So roughly speaking, it's about 250 to 300 cases a day where a patient will be saying that, no, thank you, cancel the ambulance, I'll make my own way.
Is there any more questions? Yeah, Councillor Edgeler got in there.
Thank you very much, Chair, and thank you for all your answers and everything. But we're all sat around this table as a committee, and we all care about the health of our constituents and the people out there. Is there anything that you feel that we could do to help you in your situation to reduce? In other words, I'm asking, is there anybody that we could call to or ask to come to committee and that to help you in your situation reduce the waiting times? Because if you haven't got your health, you've got nothing.
That's a good question. We appreciate the support, actually, because that is what we're all here for in public service, aren't we, in our own way. So I think 2 specific asks from us, actually. One thing that we have previously asked for, and if I remember it correctly, this committee did support it, but between the 6 integrated care boards it was for an independent capacity review. We do want an independent capacity review so we can establish what resources are required where, independently of the NHS, actually. So we could come up with it, but we'd always be accused of sort of trying to feather our own nest by, enriching ourselves with the resources. We don't want to do that. We'd want somebody to, and there are some specialists who can do this. So not just in Staffordshire and Stoke-on-Trent, but across the West Midlands, we do want an independent capacity review. That's one thing. And if the committee could support that, we'd be really grateful. The other thing that I guess is quite a very, very basic ask, actually, is for the committee to scrutinise the performance and delivery against the NHS operating standards and frameworks. So the operating guidance, the annual planning guidance that comes out from the NHS, or how our partners performing against it. Because if we were all, as constituents of it, performing against it and delivering it, we'd all be serving each other really, really well. And that's not even an extra special ask of the committee. That's sort of almost normal business to an extent. But how our partners delivering against the standards, which are really miles out. So, for example, we talked about the NHS has said no patient should wait 45 minutes this year. Well, we said there's 2,200 who waited more than that just in 1 month. So I think scrutiny of actual performance and delivery, which then leads into patient safety and outcomes, because performance and patient safety are inextricably linked. And then support for an independent capacity review would be greatly appreciated. Thank you.
Thank you. Councillor Brown.
Thank you, Chair. Thank you for listening again, everybody. I just wanted to follow up a couple of points. And I actually think the ambulance services are really having a really difficult time at the moment. I hope you don't mind me using your words already used, wasted time at home. I hope you don't take it personally, but I just want to say, having been in a situation with 999 crews, that time at home, I have seen that they're very professional, they've not rushed, and that time is absolutely crucial. Sometimes I actually think, oh gosh, should they be spending so much time and moving on to other things? But at the time, that's what was needed. And they really do work above and beyond. And also, the care and attention was second to none. Also, driving themselves. I've been in that situation as well. And the call handlers, again, I've found that they've been really careful to make sure that the people who are driving them in and the need of the patient be driven in warrants and is safe and the risk has been mitigated. I think the big thing is, obviously, just to reiterate, the white elephant is the hospital front doors. I think that's probably one of your biggest, must be your biggest problem, and perhaps you would just like to just reiterate that, if you don't mind. Thank you.
I think as far as we're concerned as an NHS body, the state of hospital handover delays is our singular biggest issue. It's not to say there aren't other things, but if you were to rank them in order of sort of priority and significance and what does it mean to us and then our constituents and partners and stakeholders, it absolutely is that for sure. Because the scale of it, as I mentioned earlier, there's 10 ambulance services, and what's going on in the West Midlands equals like 5 others added together. And if you added East Midlands Ambulance Service to West Midlands Ambulance Service, we are half of the country's delays. But we're only just 2 of the 10 ambulance services. And this is also a great point to just reflect on. It doesn't have to be this bad. It doesn't have, because it's not this bad everywhere else. And everywhere else has got the same issues of frailty, resource constraints, and everything else. You know, the West Midlands is not different to other parts of the country, actually. Why would it be? It's not. Other people have got some uniqueness, you know, the Southwest and holiday season, for example, but by and large. And even within the West Midlands, it's not as bad as this. There are other parts of the NHS in the West Midlands that do function significantly more strongly than it does in others. So whilst variation at one level is painful, it does show us other parts can do it. So we can conceivably here as well. Thank you.
Okay, I think Councillor Norman wanted to ask something.
Well, I've only been provoked to ask a question from what was said earlier, which is, well, if you want us to help you, then show us where the best practice is, and then we'll ask you if you're following best practice. What I've learnt today, it seems to me, is the barriers are really at the hospital end, because if your ambulance is stuck there, you can't be out on the road, and you're having to tell people that we can't come for a few hours and so on. So it's trying to learn where the barriers are, and then for us asking questions of those organisations or whatever, where the barriers are, to help you, I suppose, is the best way of thinking about it. Thank you, Chair. Thank you.
Well, I guess it's about following a patient's journey, isn't it? And where is the time consumed along that patient's journey? Because with that time, we're taking time off patients, and that's not fair of the NHS, actually. We're using resources, it's costing money, and it's also then of detriment to the next patient who needs that input too. But there are, as I say, there are other parts of the health and care system, even within the West Midlands, let alone across the rest of the country, which are doing it better. So, for example, you know, London ambulance services are very much considerably busier ambulance service than we are. A fraction of the lost hours to handover delays. South Central, a fraction of the lost hours to handover delays. So what's going on over there? Well, what's going on over there is that their hospitals' handover performance is considerably stronger, actually. And they've tried to be really rigorous about implementing that 45-minute standard we've referred to. In the West Midlands, that's not the case. I know we're not concerned with the whole of the West Midlands here. It's a Staffordshire Scrutiny Committee, but of course we are to an extent. But we have got a real issue here in Staffordshire and Stoke-on-Trent when it comes to it. So I guess everyone's really good at telling you what their problems are, aren't they? Now, we've done our best to try and resolve some of that, and we've talked about significant additional capacity to mitigate those lost hours. But I guess when you've got other parts of the health and care system in here talking to you about their issues, you'd also want to hear, well, what have you done to fix it then as well? Because we all relate to one another, don't we? We all have an impact upon each other. Now, I can sit here fairly comfortably and say, well, the bit that we've been asked to do is to try and keep patients away from hospital. That's what our partners ask of us. And we've got evidence to say that, well, we've actually given that a really good going. You know, we've done pretty well in that regard with the support of our partners. But I guess you need to hear from others as to what are they doing to crack this handover delay problem, because you all see the same things we see, all those ambulances lined up outside, snaking around, you know, on the ramp outside UH&M and that back out. We see it too. We get those pictures sent to us from our staff and other people. And ambulances are not a finite resource. Sorry, they are a finite resource. There's just not an endless queue of them ready to just bring the next patient. We eventually run out. And that has to stop. those, we shouldn't be seeing queues of ambulances like that. Now, if there was a dreadful mass casualty event, heaven forbid a terrorist attack, something absolutely out of the ordinary, we all get that, and nobody should be complaining about it. But that could be just any Monday of any week of any month at the minute, and that's not right, because it's predictable. That's not right. It shouldn't be, that should be the extraordinary, and it's not. Thank you.
Okay, thank you. Is that all the questions? Oh, Councillor Wellings.
Just two more questions. One for the people that come in today and one towards the chair. And I was just wondering, these smaller hospitals, for example, Samuel Johnson, I can think of the top of my head, and Sir Robert Peel in Tamworth, would it be possible to give the staff there the relevant training to ease the burden and so forth? Because I imagine a lot of the times, especially when you talk about ambulances, a lot of the times I would imagine they get called in and so forth, and having that transition from obviously ambulance to hospital, or even in a small hospital, I would imagine, I know it's wishful thinking, that would reduce the waiting times and so forth.
I'm not going to make a Staffordshire specific comment, but more broadly speaking, quite a significant sort of, as it would be in terms of the population group that ends up needing support from us, would be the care home, nursing home sort of setup, not necessarily the NHS provision of community hospitals. Now, the ICB will talk to you about all the support they've been putting in over years, in fact, to try and support them to try and maintain their residents and their patients in their place of residence ultimately, because that is their home for many of them. I think also linked to this is primary care's access. So everything we have access to by way of alternative pathways, we would want primary care to have the same access, because the 999 system shouldn't be the default into an alternative pathway. We shouldn't be the conduit into an alternative pathway. So if we were a GP practice, the three of us, and we think a patient needed some extra support, they shouldn't have to access it through us. So being able to provide all of those alternative pathways to primary care as much as it is to us would also be a big help. And in large part it is actually. GPs can call in and use a lot of the services we can. They're not ring-fenced for us in any meaningful way. So then we start to talk about things like step-up care. Can GPs actually get patients admitted to those sorts of places, and all that sort of stuff? That's not necessarily for us to be getting into. Maybe a question for ICB colleagues, and also their throughput, because actually if they got beds they need to turn over to, they may have their own delays that they need support with as well. Those are sorts of things we're not so well cited on. There's definitely a part to play, because actually if you're a very complex, frail older patient, you can have an incredibly long length of stay in the hospital if we don't get it right. And if we can intervene and get ahead of that, you can actually really make a difference. Because if you look at someone in a nursing home, and what's the average life expectancy of somebody in a nursing home, we should not be taking days off them unnecessarily, because actually, in some extent, if you're in a nursing home, your expected life expectancy thereafter is not actually all that long. It's almost like an end-of-life pathway to some extent. So actually, it's incumbent upon the NHS to not take days off patients actually through wasted time, and as best as we can by maintaining them as far as we can in their own place of home, which could be a nursing, it could be at home. So then you get into the discussions about what wraparound support can we put behind frail older patients to keep them at home and head off certain issues and things that they invariably deal with. But perhaps a question for our partners, I suspect, more than us perhaps. Thank you.
Thank you. Thank you for asking all my questions as well. Just the other one towards the chair and so forth. And would it be possible to request a visit to the Stafford call centre? And so. Okay.
Yes,
I'll beat someone to it.
Already been suggested by Charlotte, which I was going to bring up at the end in the next part of the meeting. So, is everyone's questions? Is that Anne?
Can I just come? You've raised about care homes. Is there any way that say community first responders and that can go into care homes and just to prevent people using an ambulance and going in, having to go to hospital? Is there any mileage in somebody going in there and just, talking to patients or talking to the carers and find out if there's anything, I'm just trying to help the situation by asking that question.
I don't think it's about volunteer first responders going into care homes, but absolutely about community first response. So the urgent community response schemes. So, they're staffed by a lot of advanced practitioners, a lot of people with expertise in frailty, people who can prescribe, people who can manage people with some exacerbation of conditions. They can do those sorts of things. So there's definitely mileage, and they do some of that work. Partners will no doubt be able to explain to you whether there's more mileage and support that could go in. I don't know the answer to that, but it's not necessarily about the first responders going. It's more about urgent community response, who can and do make a difference in that area for sure. Thank you.
We are going to be closing this after this, Councillor Brown, so if you'd like to ask a quick question.
Yes, I will. Thank you, Chair. I realise everyone's been here a long time now. I just really think it's really important to, obviously, Samuel Johnson and Sir Robert Peel have been mentioned. Currently, the minor injuries unit or urgent treatment care centres are currently staffed by nurses, and there's no doctors there. They're doing an absolutely amazing job. They're currently up to capacity themselves. There's no medical cover there. So currently, their role extension, I think, would be fantastic if we go back to having GPs there, because GPs used to have sessions there. And I think, yeah, it's an excellent resource that's there, but at the moment, I'm not aware that there's going to be any medical cover, and obviously that would be the next thing. So, yeah, just wanted to just put it out there for your information. Thank you very much, Chair.
Okay, thank you for your presentation and coming to see us. Could we request to have a breakdown of the response times for district and borough? Is that okay with yourselves?
What we'll do, if it's okay, it may be that we might actually do it by postcode rather than sort of districts and boroughs. I'll just see how we can sort of carve it up. But we can certainly, if Zach, if you're to give me the specific ask, I'll respond with it. Thank you.
Do we want to see a briefing report from the acute hospitals to ask how they're working towards the 45-minute handover commitment? Yes, it's my laptop. I got Zach to write it down because my laptop's playing up today. Is that okay? Yep. Okay, so we'll get that for everybody. I'd like to take a quick 5-minute comfort break. And thank you for coming, and we really appreciate your presentation, and we'll be back in 5 minutes. Okay, thank you everyone. We're back on now. So next we've got the Staffordshire and Stoke ICB with their report from the SSOT ICB. Then you're going to present that to us. And welcome, thank you for coming.
Thank you, Chair. And as most of you know me, I'm Tracy Shewan, Director of Corporate Governance for Staffordshire and Stoke-on-Trent Integrated Care Board. I'll just allow my two colleagues to introduce themselves. And apologies, Dr. Fawcett has had to leave. He's had to go to a clinical commitment. So my apologies for that. We did want Dr. Fawcett here.
Good morning to the committee. Thank you so much for inviting us to come and talk today about our winter arrangements. I don't think I've met you before, so I'm Hayley Allison, Portfolio Director for Delivery and Improvement for the ICB, and I'm here with Tom. I'll let Tom introduce himself.
Yeah, good morning to members of the committee. Thank you for giving us the opportunity to speak today. So my name's Tom Bailey. I'm currently the ICB Head of Community Transformation. However, I'm here on my substantive role, which was the Urgent and Emergency Care Delivery and Improvement Lead. So lovely to speak to you all.
Welcome.
So I am aware that we did submit quite a lengthy report to members, so I hope that that provided quite a good background into the topic that we're going to go through today. We don't have a presentation, but we are just going to run through a few headlines. And actually, I think it's really timely that the ambulance service came along this morning, and this will follow, because I think it will help to join up some of the improvement work that is taking place across the health and care system. And I think it's a really good suggestion that we do come back with hospital partners. So again, to really strengthen that level of understanding around the wider improvement work in the urgent and emergency care area. So we're specifically going to talk about the winter arrangements for this year. And I think we've been to many committees to talk through our intentions, and I think it's been received really well, and I guess it's really important to come out and talk to really broad groups of key individuals across the health and care community to really understand how we strengthen our plans and how we learn from previous winters. And a key feature of our winter plan this time has been around how do we really learn from what we've done. We've had some really difficult winters in this system. And how do we identify what good looks like? And we've picked up some of that already this morning around, patients waiting extended times for ambulances. It's not acceptable. So what can we do differently, collectively, to stop that happening? How do we make sure patients receive care in a timely way when they go into an A&E department? So the national target is for them to receive care, to be assessed, treated within 4 hours. And at the moment, we're not achieving the national standard. And there are many other indicators that really dictate the quality and the safety of the care that our population are receiving. So for me, that was our starting point. What does a good winter look like? Well, for me, it's good access and timely assessment and treatment. And also, more importantly, I think, is for patients to receive care in the right place. Hospital isn't always the right place. So we focus quite heavily this time on, yes, we absolutely need the right level of capacity in terms of bedded capacity for those patients that do need to go into a hospital bed. But for me, it's much more around what are those alternatives to hospital? How do we make sure that clinicians get access to the relevant support and advice rather than an ambulance just being called as a default position? So between Tom and myself, Tom will talk through the capacity modelling that we undertake, because that is incredibly important to make sure that we can respond to those real peaks in winter. You'll all know about infection and prevention control, so things like COVID, norovirus, RSV, flu, all of those things we see in a much more increased way through the winter period. And what's happened in the past, in previous winters, is that we've had all of those infections happen at the same time. So that puts incredible pressure on the NHS. So through our modelling, that we try to mitigate some of that impact. So, like as I said, we'll come on to the modelling side of things, but I just wanted to talk a bit about some of the alternatives to hospital that we have in our winter plan. So, we had a learning event back in May of this year, but you'll also be aware that last winter we had a number of critical incidents that they were in response to, on the whole, issues with capacity and demand. So not being able to meet the demand that was coming through the front door in our acute settings. And I guess when we go to critical incident, that's when, as a system, we have to look to what additional actions can we undertake, and they're usually very extraordinary actions so that we can maintain the safety for our patients. So we've taken all of that learning from those critical incidents that took place last year and our learning event with all partners across the system to develop our plan. And we've picked out some of the things that we needed to do differently. So we have, across the system, something called the Integrated Care Coordination Centre. We might refer to it through our paper or in the presentation today as the ICC. So that is basically a single point of access for clinicians. So if for example, if an ambulance crew were at a patient's home assessing, weren't sure whether they needed to go into hospital, is there an alternative pathway for that patient to access, the ICC could support with identifying whether there is an alternative. We started out with an ICC, I think it was 12 hours a day. And earlier this year, we extended that to 24 hours a day. And what that means is that each day we have a significant number of patients that are redirected away from a hospital setting. Or I might rephrase it to say they access care in the right place. So they might have a community team come in to see them. They might have a virtual, you've probably heard about virtual ward capacity. They might go onto a virtual ward. They might be seen by primary care. That might be appropriate. So it's been a real success for us. And one of the things through winter is our intention to increase capacity in the ICC so that more patients can be redirected from going into hospital where it's not appropriate to do so. The second area is around, you heard from the ambulance service, the challenges around ambulances that are waiting to be handed over into the care of the hospital team. It is fair to say we do have some inappropriate conveyances, and we're working really hard to learn and understand why that happened. So the reason Dr. Steve Fawcett's had to leave this morning is we've introduced a clinical process, a weekly clinical review of patients that have been identified as being conveyed inappropriately to the hospital, so that we can understand, so was there a reason for that? Was it a lack of access into something like the ICC? Was it a complete gap in pathway, so there wasn't an alternative for that patient? But I think the principle around learning and understanding is really, really important here, so that we can make sure that we put in place the best service model that we can for our population. In the winter plan, we funded things like additional primary care appointments. We hear about primary care access at times not being where it needs to be. So that's been a core feature of our winter plan for this year, and something that we've learned from previous years as well. Something that works, but it's focused this time around primary care hubs that can see patients from a broader population. There are lots of other areas as well around our investments for winter. So it's not all in the acute setting, so it's increased capacity in the community setting. So for example, we've got some additional capacity in Cheadle. And then the other key area that I'd want to point out is just around vaccination. We know that if we could do better around the vaccination programme and more patients access that, then that would in turn reduce the number of patients that end up being unwell or seriously unwell and requiring a hospital admission. And if UHM were in the room with us today, I'm sure they would talk about last year, and again, this has come through our learning, that there was a number of patients that went into the hospital setting, perhaps for an outpatient appointment, that were exposed to the flu virus, and then that cohort of patients then converted into being at the admissions into hospital a number of weeks or months later. So it's, you know, absolutely it's what happens. So our focus on vaccination, some additional resources into making sure that patients going back into the care home setting are vaccinated, patients that are coming in for an outpatient appointment are offered the vaccine, and then of course you've got the usual vaccination routes through your primary care or pharmacy type provision as well. I think just a little bit, I'll talk a little bit about oversight of winter. So historically, the ICB have been the body that have held together the plans around winter, which remains true for this year. But one of the things that we've worked really hard to do is develop more of a shared ownership framework. So we've introduced a winter oversight group that consists of all partners across health and care. We've developed a model that has 13 pillars. I think you would have seen this in the paper we submitted around all of the component parts of our winter plan. And I guess it's around holding organisations and individuals to account for delivery of some of the core areas of work. So that work is ongoing. That group meets fortnightly. And I think one of the things that's important for you to know is that as the demand fluctuates in the community and requirement for ambulances and requirement for hospital admission, we flex our plan according to what is needed. So as an example, the last probably 3 weeks have been incredibly pressured in the acute setting. So we've brought forward some of the opening of our additional capacity at the Royal Stoke site, and a small amount at the county site as well. So we'll do that, we'll bring forward capacity, and we'll escalate and de-escalate as we need to do so, because we feel that that's really important to support with the additional demand, but also try and reduce ambulance handover delays to the most minimum level that we can manage within the capacity that we have. So I'll stop there, and I'm going to hand over to Tom, and Tom is just going to talk through the modelling process that we go through, and then perhaps we can take questions after that. Thank you.
Thank you, Hayley. So just for councillors' reference, page 25 of the pack kind of describes some more of the detail on the modelling, so I won't rehash that, but more than happy to clarify any points, take any questions. In essence, what we seek to do with the modelling when we approach winter is understand the level of demand that we can expect throughout the winter. And I think throughout all of the modelling work that we do, we try and assume a worst case scenario. So Hayley mentioned about the different levels of infections peaking at the same time, the levels of flu, COVID, norovirus, etc. What we seek to do is model all of those aspects to occur simultaneously, concurrently, at the worst point, which is ordinarily in January. The start of January tends to be the worst point of winter in terms of the highest levels of demand, the sickest patients, the highest levels of acuity, etc. So the modelling is built upon trying to prepare the system for the worst case scenario. And then we do that in order to kind of increase the level of resilience that we can then put into the plan. So the different mitigations that we put into place, the different schemes that we bring online, when we bring them online, and how we kind of build in that trajectory. We don't want to waste resource. We don't want resource opened or in utilisation, which is not required. And that's where the Winter Oversight Group comes in, because fortnightly we have an assessment of what level of demand is there. If we need to bring things forward, as Hayley has referenced, they will be brought forward. If we need to scale things back, which is rarer, but we do it, then we can scan those things back. I think, again, really with the modelling, the key aspect at the outset is to build upon learning that we have. So the modelling tool that we utilise across the system, it's the 4th winter that we've utilised it. It was developed in in collaboration with the Acute Hospital Trust, with other system partners, and PwC kind of did some of the architecture for us. They utilised their, obviously, vast resources and modelling skills, but also that independent aspect to kind of assess capacity within the system and how we can best utilise it. So it's the 4th winter that we've used the tool. At the end of every winter, part of the learning event that Hayley referenced in May, we review that week by week. Where were we? Where did the model suggest we would be? Where were we in reality? What was the demand like? What were the levels of infection like? How many patients were waiting in the department? So the ED at any point waiting for an admission, etc. All of that is then utilised, it's built upon. And I won't go into the technicalities of it too much, but essentially what the model does is go down to what we call the spell level data. So that's for every single patient that's admitted, their time in hospital is referred to as a spell. Every single person that's admitted, every single person that attends A&E throughout the winter, that data is captured and then feeds the model to kind of give it the level of granularity, the level of real depth that we can actually then utilise to move through. There are underpinning assumptions which we can tweak, which we can change. So if we are seeing an earlier flu peak, which it feels like we very much are at the moment, we can bring that further forward. If we're seeing increased instances of coronavirus, norovirus, etc., we can then move those things through. If some of the mitigations that we propose and we've put in the plan are not delivering at the levels that they are intended to, because there may be building works, there may be staffing implications, we can then tweak that so we can actually look at deploying resource elsewhere, bringing things online, playing with the trajectory. And that's what the model allows us to do on a week-to-week basis. Within the pack, you'll have seen the waterfall chart, so that's on, I think, page 26. So this is the kind of colourful bar chart that moves through. It describes the levels, the impacting factors which essentially describe the system demand. So within there you'll see excess demand, which is the degree that the model suggests. If we did nothing, if we put no capacity in whatsoever, the hospital would be, in this instance, on our worst day in January 2026, 156 beds short of what's required to deliver the demand, to cope with the demand that's then seen. There are then additional kind of factors which we build in to increase that resilience, so infection prevention restrictions, temporary escalation spaces. So in previous winters, and I know it was in the news this morning on my drive up here, use of places like corridors to care for patients. What we want to do at the outset is try and mitigate those as much as we possibly can, take out the need for that. We also put in levels of D2A. D2A is decision to admit, so that's a patient sitting in the emergency department who has a decision to admit, but there's nowhere for them to go as yet. Again, we don't want that to happen. The colourful bars then working through from left to right are the mitigations that we're putting into place to offset that level of additional demand. And again, it's kind of built through to give us as much resilience as possible to address the worst case with all those infections peaking at the same time and kind of all of the worst things that could happen happening at the same time. So that's kind of our worst case scenario and how we seek to pitch things to then mitigate it. Obviously within the pack, within the papers that you've received, there is a figure 3, which is the UHNM aspect. We do also model, work very closely with colleagues from University Hospitals Derby and Burton. So we do in our full winter pack have Queen's Hospital Burton modelling as well, which works through. Colleagues I'm sure will be very pleased to hear that the Queen's Hospital Burton position is not as severe as we enter into winter. So the modelling work we've undertaken with colleagues from UHDB suggests that, broadly speaking, we will have enough acute and escalation capacity to deal with the levels of excess demand as we move through to winter. Members of UHDB are members of the Winter Oversight Group. They come to our weekly system surge meeting that we call, which kind of is where we assess the efficacy of the winter plan, the mobilisation, the deliverability, etc. So we do have that holistic view across the system in terms of where we're at, where we need to change things. And I think that the recalibration, I'll use that term, of the plan, I think is something which we've gotten better at. So this is the 4th winter that I've been in Staffordshire. I think every single year as we've moved through, we've utilised the learning, we've harnessed it, we've made sure that the modelling and some of the information that we put out to system partners is more nuanced, is more reflective of the realities. And I think that's helped us to actually react and be proactive in terms of those demand spikes that we see coming, so we can deploy the resource in a better position, earlier, more timely, etc., to hopefully offset the need for things like critical incidents. But I'll pause there and hand back to Hayley.
Okay. I think just in terms of additional information we'll present to you today, I think we'll probably leave it there if that's okay, because as I said, we did submit the report to you and happy to take any questions.
Okay, yes. Councillor Kelly.
Thank you. So we discussed earlier about the 45-minute wait time, and that is a government, what they would like you to do. What are you doing to try and meet that goal? That's my first question. I do have some more. Shall I do them in a row? And then...
Yeah, can I take them one at a time? Is that okay?
Yeah, that's fine.
So you're absolutely right. The 45-minute handover ambition, let's call it, is a really important one for us. But I think having been in the NHS a long time, I think it is really important that the actual national standard is 15 minutes. So, you know, it is significantly longer than what we need to be working towards. So we're really, really mindful of that. And all of the things that impact on the ambulances not being able to hand over, it's not a single thing. It's not that the staff aren't working quickly enough. It's fundamentally that the flow of the urgent and emergency care pathway through the hospital into the community is a bit stuck, just in the most basic way to describe it. So what you'll see, I'll take Royal Stoke as an example, what you'll see in that department, I can talk about today, you'll see that there'll be about 150 patients that are sitting there in totality. There'll be about 35 patients that have been assessed, have gone through that assessment process by a medic and a nursing team and a therapy team potentially, and will be deemed to need an admission to hospital. So they'll be waiting for a bed across the wider site. There'll be a number of assessment areas across the hospital that have ended up having inpatients. So it should be a rapid assessment, but actually what happens is those beds end up getting used for a patient that's needed to stay overnight. On some of the wards, what we'll see, we have, I mean, it's had very many terms over the years, but it's essentially, you might have heard it as boarding, on wards. So basically, if a ward has 24 beds, they might be plus 2 patients. So they'll have 26 patients to care for instead of 24. So the pressure that I'm trying to describe goes across the entire site. It's not just in A&E. And then at the back end of the hospital, you'll have a number of patients that are waiting discharge. And they're often complex patients that need, you know, they can't just go home. They need to go home with a care package, or they need to go on for ongoing assessment to determine what their future care needs are. And what we've seen across health and care is that the complexity of patients, you know, is increasing all the time, isn't it? Patients are living longer, and so what they need is much more complex than sometimes the resources that we have. So in terms of additional actions, so that we can go in right back to how do we support the front door to be able to hand over those patients as rapidly as possible, is not just about what needs to happen in A&E. What we need to be able to do is create that flow through the hospital. So get those patients out at the back end, that's really important, and make sure that things like the length of stay of patients that are in a bed is within the required parameters. So we'll talk about things like hospital processes. So if we've identified an estimated date of discharge for a patient, how does that clinical team work really well and focuses on, we've got to get that patient out by that date. And you know, things are really complex. Sometimes families don't want to accept the patient home, you know, and that can be a complexity and can mean that a patient stays in hospital longer than they need to. So what we need to do is tackle all parts of the system. There's no one magic answer. I wish there was, actually, but there really isn't. There's lots of things we need to influence. So alongside our winter plan, we have something called our UEC improvement plan, and that looks at all parts of the UEC pathway and looks at how we might strengthen that. So a couple of things that are in our report but I didn't mention. So we're mobilising our urgent treatment centre model. So there are various facilities across the locality of Staffordshire and Stoke-on-Trent. So things that might at the moment called MIUs. So we're looking at, so how do we get additional capacity in terms of the types and range of conditions that those walk-in facilities can manage safely, so that that redirects patients from the front door. We need to stop patients going to A&E that don't need to be there. So there's lots of different aspects to that. So one is the ICC extension that I talked about. The other one is a deployment of a UTC at the front door at Royal Stoke. And then with a longer term plan around having, well, there is going to be one at UHDB as well, and then looking up in the future one at the county site. But all of this requires investment, so that's why we're not doing it all at the same time, obviously. And then looking at towards the back door, so how have we got the right assessment capacity in the community so that patients can move through in a really timely way. And I have to say that from a system partner perspective, the local authority work really closely with us on making sure that there's the right capacity there so that we can move those patients through. I think the collaboration in this system is really excellent, but obviously we've got quite a long way to go just to make sure that we can really start to focus on the achievement of the 45 minutes. Over the summer period, we did really well and had quite a few days where we were beneath the 45 minutes, and you know, clearly we need to be able to do that in periods of pressure as well.
So you mentioned the designated urgent care treatment centres. So when will they be designated? When will you decide where's where? Because as Leek Rural, I would like to put forward the Moorlands Hospital in Leek as a definite option for one.
Yeah, so those of you that have been involved in the UTC agenda, it's been going on for a number of years, hasn't it? And what we've seen over that time, NHS England have adjusted the expectations. I think is probably the right term to use. So myself and my team, because it's been going on so long, we are working on finalising our proposal for the end of this calendar year. So we're going through our governance. I haven't got the exact dates in front of me, but we're planning to do that during December. NHS England have, again, changed the requirements for, because we've been given various deadlines over the last number of years that we had to achieve it by this point, and then it was changed, it was rolled on for another year. And we have just been told that it's been rolled on to 2026. But from our perspective, we're really clear that we need to get this resolved. And I think the operational planning guidance that was released this year was really clear that having co-located urgent treatment centres with an A&E department is the right thing to do, because it means that we can stream at that very front door to say, no, you don't need the care of an A&E, you need to go into a UTC. So from a Royal Stoke perspective, I think it was December. It's December that should be mobilised. But of course, there's a designation process that we have to go through that is governed by NHS England. But our proposal will outline all of the timeline around that.
And just as an aside of that, we'll let committee know, because if it's a discussion that's got to be in public, because it'll be at our board, we'll let committee know through Zach, so you could either watch it or, you know, obviously ask questions at it, because I know it's been something that's been around for a long time, so we will let you know. Yeah.
So my next question is, again, on more on what you discussed. My baby's recently been in the hospital last month. He was really ill. But what could have prevented it is if there was more GP appointments. So then, if he got sore sooner, had the antibiotics before. But unfortunately, there were no GP appointments that day, so we ended up at the hospital when perhaps that could have been done at a GP's appointment. And then again, I want to discuss infection prevention, because when you're waiting there in long for long periods of time in a room full of 6 people where you don't know if they've been treated, where some of them haven't been triaged yet, and there's norovirus going around, COVID going around, this can then increase the amount of people going in to wards, spending longer in hospitals, which could be prevented then.
Yeah, so I'll be really honest, I don't cover primary care as part of my portfolio, but what I can say from a winter plan perspective, we have commissioned enhanced primary care appointments for the winter period. So I think they're going to be available from the 1st of December. So, yeah, if there's anything wider primary care that you would want to know about, I would need to take that back to the primary care team, but happy to do so if that's helpful to you. And then just on the point around kind of, I guess it's the spread of infection, isn't it? Within the NHS, there are guidelines around mask wearing. And when an infection rate is at whatever level, that's when hospitals would consider the rollout of wearing masks across the entire site. And in fact, that point did come up, I think, because we went to the Stoke Overview and Scrutiny Committee last week. So it is something on my list just to follow up around how we ensure that that is deployed at the right point in time.
Sorry, the primary care is coming on the 26th of January. Yeah.
So, as you said, that during using the winter plan programme, you said that it could be adjusted earlier on to come forward, to make it sooner. Winter's come on early this year, and yet you're saying that the increased primary care options aren't coming into the 1st of December, but winter started 2 months ago.
Yeah, so when we make considerations around the earlier mobilisation of schemes, we obviously do that balanced against all of the other things that we're planning to deploy. And we did consider the early mobilisation of the primary care appointments. And it's not to say we've closed that down. This was just a conversation last week around whether it's the right time to bring them forward. Because of the number of patients that were in hospital awaiting discharge into a discharge to assess bed, we looked at our investment, because, I mean, you know, you'll be well aware there's only a finite pot of money here, and if we mobilise something too soon, it will need to end sooner at the other end of winter. And of course, you know, winter hasn't got this kind of neat 5-month window, has it? You know, it has a habit of going on into into Easter and beyond, and we know Easter's a bit earlier next year. So just because we haven't done it earlier doesn't mean we're not going to, but we did, in the last couple of weeks, we have mobilised quite a few of our physical capacity schemes to come on stream earlier so that we can manage the demand that's sitting within the hospital.
Okay, thank you. Councillor Brown.
Is it still good morning? Thanks very much for coming. I'll try and be brief, but I've got quite a few things I just wanted to raise with you. Firstly, obviously, this is your winter plan that I understand from reading what you submitted, that it can change as it goes along. I'm still really concerned that even though you've made changes, it's already been activated 3 weeks ago, and we're still losing 41,000 hours last month ambulances, and obviously you heard that conversation or debate this morning, but it's not changed. This winter plan is not changing these hospital ambulance door waits. So I'm really concerned what you take away, or what you're willing to take away from this morning's discussion, including what I've raised, so I won't repeat myself. I also want to bring to your attention, we've obviously mentioned the community hospitals and urgent treatment centres. East Staffordshire Borough Council and Derbyshire have already got theirs in place. There's an awful lot of NHS England money floating about. I'm fully aware of that, but it has no medical cover. And again, GP appointments, I'm always hearing from patients I see continually, there just aren't the capacity for GP appointments. it is a huge, huge area, and what I'm hearing this morning, I'm seriously concerned that there's still not enough, and these aren't, did you say, not going to be activated till December? And if I can just check, the Learn from London. London don't seem to have the same issues, we were told this morning. Please, do you not learn from other sites, or is this something that you could look at in future? And I think I'll leave it there for now, please. Thank you very much for listening.
Yeah, that's fine. So I'll just take each area, if that's okay, separately. So the hospital handover delays, we absolutely acknowledge that the loss of hours where we don't have those ambulances back on the road to be able to respond to another patient is not an acceptable position. It's broader, that the issues are broader though than just putting additional capacity in place. And I guess we have a plan, as Tom outlined. We go through the capacity and demand. We try to understand what the demand is, but all it takes is one of the metrics to change. So I'll take the increase of flu as an example, because if a hospital that has a number of cases of flu, they have to isolate those patients, which then extends the patient's length of stay. So what we're seeing at the moment at the acute site is a really high number of patients that have been in hospital for above 21 days. And then our length of stay, we normally work on an average length of stay, and in our winter plan, we've assumed an average length of stay. I think it's something like 2.5 days. We're currently at about 7 days. I mean, this moves all the time, so bear with me in terms of those numbers. But that metric in itself takes out of the hospital so much capacity, because what we end up with is a whole load of patients that can't be moved because of their infection status. And then sometimes we end up with empty beds in a bay, say, that can't be utilised because the other patients in that bay have an infection. So it's a really complex picture. It's not just about mobilising more and more and more, because from a workforce point of view, Vivek clearly said, we just don't have the trained and skilled workforce out there to keep opening more capacity. We do have additional workforce over the winter period, but that is managed in a kind of staged sort of way, so that we can move staff around sometimes. So the change in the elective, the planned care programme is a factor over the winter period, but we can't take planned care down for an extended period of time, otherwise that impacts on patients that are waiting planned procedures. So it's a really fine balance. So absolutely support that we need to reduce our hospital handover delays and the associated lost hours. But there are lots of things we need to do across the system. One is around the education of our population, not going to access services inappropriately. And I know that's a really difficult thing to do, but it's a commitment that we need to make through our UEC improvement programme to get patients to be at the right place. And things like having a co-located urgent treatment centre at a front door of a hospital is really important. So let's stream those patients to reduce the congestion in an ED, because working in a congested ED, I know have previously worked in hospitals, is really, really challenging for the clinicians, for the staff, but most of all for the experience of the patients. It's not, it's not a nice environment to be in. Any of you that have been, I'm sure most people have been in an A&E, it's not a great experience. So the decongesting of the A&E has to be the core focus so that we improve that flow through a hospital. And then a lot of the other things will fall into place. And then you mentioned primary care.
It says medical cover urgent treatment.
Oh yeah, medical cover. Which urgent treatment centre was that you referred to?
I'm not aware that any urgent treatment centre currently has medical care.
Yeah, so that's part of the specification for the service. So if there's a specific example of a site where you believe that isn't in place, then if you could let me know directly, and then I'm happy to investigate that. But so Royal Stoke, as an example, they don't have the UTC mobilised yet, but they've got an alternative service which is it's called EHPC, so it's Enhanced Primary Care, and that is staffed by some GPs and nurses that support that. So as far as I'm aware, we do have the medical cover, but it's primary care cover usually.
Sorry, can I just follow up, please? Thank you very much. Thanks for all this. Yeah, I understand it's broad and complex. I just want to, there's a couple of things. I'll try and be very brief, and so I'll talk very quickly, if no one minds. So, for instance, you've got an old person, they get an infection, can't see their GP, they get a worse infection, they get pneumonia, they get sepsis, they end up going to hospital and need a bed. That can therefore be a young person with underlying health conditions. Same thing happens. So, yes, we can talk about primary care, but we are here to also, obviously, to speak about the community and your area. And I still don't feel that the question's been answered about your winter plan is already fighting fires. That was 3 weeks ago. Again, I'm just concerned that there isn't a dynamic approach going on here. And I'm concerned that you're just fighting fires and your poor staff and everyone else is just going to be in a situation going forward, and you must agree that's happening. I'd just like to raise, is GP contracts, is that part of the problem as well? Because when GP contracts changed, that's obviously we lost a lot of GP capacity, and I'm really concerned about that. I think I'll leave it there, thank you.
Just on the GP contract, it's a great question for when the primary care team are there, and there's a lot going on around the GP contract at the moment. But you've also seen about the neighbourhoods and what we're doing going forward with neighbourhoods, and GPs will be central to them. I think about the extended access that we talk about, it might be that we probably need to let you know where that is, because the hours, because what we do with extended access at the moment, you know, you phone your GP, don't you, and you get an appointment within your general practice. What we're looking at extended access, I think you said, was the wider geography. So there's, yeah, they're coming together. So a hub and spoke model. So there will be wider access for individuals. So, like I said, we're not the experts in primary care, but I need to know enough about it anyway. But for us, hopefully, you know, last year we saw, I think they called them winter clinics, which were really helpful respiratory where there was respiratory illness, because then people could be seen earlier and did prevent some of those admissions to hospitals.
And just to also add to that, so another area that we focused on for additional capacity is around dedicated respiratory clinics. So we know that obviously respiratory is the kind of one of the key things that impacts on increased attendance or admission into hospital. So that is at the moment one of our areas of focus, and that is being led by UH&M. It's a small project at the moment, but it'll be something that as we evaluate it, if it's something that is really successful, we'll be able to do more of that.
Sorry, can I just come in on just for a point of clarity? So the 40,000 hours lost by WMAS, that was across the West Midlands. Just for a point of clarity, it wasn't just Staffordshire, just to make that clear.
Okay, that's great. Thank you very much. I apologise if I didn't make that clear. And obviously, just to say, you know, as simple as, I think, that's what I'm trying to say, is it's not very joined up at times. One of the issues is, you know, someone in the late 60s turning up somewhere, going quite a distance, 25 minutes, 30 minutes for a flu vaccine. They're not allowed a COVID vaccine. You know, why aren't we giving people the vaccines? Also, it's much nicer to take elderly relatives to a local surgery to get these vaccines done rather than going 30 minutes. And it's all these things that people won't attend, they won't have the vaccines, which has been mentioned by, you know, the Vice Chair. And I think that's what I'm trying to say. I just think we're lacking a bit of dynamicism on this. So thanks very much for listening. I won't say any more.
I'll just come back on the vaccine, and there is quite a lot available local, because pharmacies are doing vaccine as well as general practitioners. So anywhere that's struggling and thinking they're not local, please let me know. In terms of the COVID vaccine and the decision on who's vaccinated, when they're vaccinated, it's down to and I get it wrong every time, it's the UK, it's a virus,
JCVI.
the JCVI, the Joint Committee on Vaccinations and Immunisations, and they set the bar. This is the people who will receive this for free this year. So we have to work within those parameters, and those are the ones that were set for COVID vaccination.
And just to add to that, so that's one of the core reasons why we have invested in vaccination taking place in the hospital setting. So the outpatients, patients on discharge, patients being discharged to a care home. It's trying to wrap up and kind of mop up all of those patients that haven't yet been vaccinated and are going back to a setting where, you know, there's the potential for any kind of further risk. So we hope that that's going to be really successful. We haven't got the numbers around our vaccination programme yet. They don't start until, we think it's this week actually. But all indications so far is that we're doing really well in this area on vaccination. So it'll be really good to evaluate the additional investment that we've made in vaccination to see of that impact.
Thank you. I'd just like to say, Councillor Johnson, I do apologise. I have got your name on my list to ask a question. So we have a list. Thank you, sorry.
With it being my first meeting, I didn't know how it worked to actually attract your attention. Thank you.
It's okay. Councillor Norman.
Can't believe you wanted to jump in front of me. I've had my flu vaccination. You get the text from the GP, and then you still get 3 more texts from the NHS even after you've had it. I don't know how to stop it, but you know, I've had that and the COVID, so I'm grateful for all that. All works well for me. I'm also just mentioning about hospitals. It's always about the north of the county. Well, the hospitals I'm interested in are Walsall Manor, New Cross, and even Good Hope to some extent, south of the Lichfield district. So, you know, just to mention that. I did have questions about what you've learned, but I've heard from the speakers how much you have learned, and you're always learning. That clearly is the case, but still feel obliged to ask those questions. But you've done that. I just wondered if there's anything significant this year from last year that you hope will be a success. I just wondered if there's anything particular, some method. And the other thing is about the, you just mentioned it as it happens, that the neighbourhood teams. I've just said a little bit for my benefit, but others can listen in, obviously, only a little bit about what an integrated neighbourhood team looks like. That would be helpful for me. Thank you.
Yeah, thank you. Yeah, really good question. I think just in terms of our broader learning, there's always going to be the core things we do around additional capacity, because our modelling tells us at points in time throughout the winter period we need more beds, and that is just fact. So we do have to invest in those, unfortunately. You know, it's required. But I think for me it's more around the areas of innovation and doing things differently. So one of the schemes that will be coming online at the beginning of December is an X-ray car. So you'll all know that fallers are a real challenge for us as a system. So if a patient falls and if they're elderly and there's a query around whether there's a fracture, they will be conveyed to hospital. And, you know, it's not necessarily always the right thing for that patient. So we are going to be testing an X-ray machine in a car with a radiographer. Couldn't think of the word then. So, you know, that has, you know, you talked about learning from other areas. That was something that Portsmouth did, and it was really successful. So we're testing it, and it's partially being funded through some charitable funds from UHM as well, just in terms of the equipment side of things. So if it's a real success and it prevents patients going into hospital, even if it's small numbers, it's really beneficial, because, as we said at the beginning of this, if patients don't need to be in hospital, then they shouldn't be there. And then just onto the integrated neighbourhood offer. So there's a national specification that this is, again, is not my area of expertise. Tom might be able to add to this as well. But this is around better coordination of existing resources in your local community. So some of that will be standard things like community nursing, obviously some of the primary care type services that are on offer, kind of local therapy. Anything, Tom, to add? Yes, yeah. That's the word.
Absolutely. I think that the integrated neighbourhood teams absolutely speak to Councillor Brown's point about bringing services closer to patients, making it easier, making it more efficient. So if a patient is attending a health setting, they don't need to attend 6 different health settings for 6 different things, and kind of building that efficiency in to actually make it more of a neighbourhood offer. It's at the early stages. We are kind of in the piloting stage of it. We are utilising the national specification, but I think conceptually, I'm sure everyone would agree that that's the right thing to do. It's about making sure we have the architecture behind it to ensure it functions the way that it's intended and actually reap those benefits. But yeah, absolutely, it's going to be key moving forward for the system and indeed across the whole NHS.
Just to say that, I miss sloppy slippers and those other examples that we had to try and prevent the falls in the first place. I did need the X-ray car coming to see you, but I think that's going to be interesting to see how that works. But as I say, if we can stop the falls in the first place, that'd be even better. In my previous life and another role, would be supportive of that. Thank you, Chair. Thank you.
Okay.
So, Chair, may I just respond about the falls? There is a whole campaign about, and working with local authorities as well, on this call, not fall. There's all sorts of things. And you're absolutely right about slippers. Absolutely right. So there is something that we work on in our communications campaigns as we work alongside the winter programmes around things like that. So you're absolutely right. Prevention of falling is a major thing.
Okay, thank you. Councillor Doherty.
Thank you. So going back to the 40,000 hours lost and talking about efficiency, how many hours are lost due to inefficient digital software? And I've raised this issue before, in that when a patient goes to hospital and they've been triaged and they're admitted, when they have to go to different departments, they're triaged every single time. That information should be there, available, ready for GPs, consultants, nurses, and then you get like locum doctors that come in that don't know, and then they have to be triaged again. It just seems like an awful waste of time to me. Thank you.
Thank you, Chair. Yes, so just I agree if you're having to be triaged. So we do have the One Healthcare record across Staffordshire. It's Staffordshire, Shropshire and the Black Country. And Chris Eibel, our Chief Digital Officer, leads that and could give you the proper answer and the hours and the real detail, on that, with that. So maybe that's something I'll respond to Zach with. But that has got to be an ultimate ambition. And obviously with data protection rules within it as well, because, we have to ensure we protect the individual. But that's got to be absolutely, and we have it in a small sort of scale, but we need to go further and faster with it. There are certain amounts of information that's available to ambulance service if you're there, So you're quite right, it's just something we've got to go further and faster. But I'll probably get Chris to do perhaps a briefing with the Chair's permission. If that's something you want, we could just do on where we are with One Healthcare record.
Any follow-up question? Okay, Councillor Parton.
Good afternoon. It's changed. My question is about the beds. A friend of mine was in hospital recently. She'd been in a couple of weeks. And she was told in the morning she could go home. She was left in that bed until about 6 o'clock at night, waiting for all the other bits of information, waiting for packages and everything like that. Could there be a side room or a room where these patients waiting to go home could be put instead of blocking a bed and holding the bed up? Because there was 3 of them waiting to go home, and they were all in the beds waiting to go home. Those are 3 beds that could be put back into use. That's just an observation and a question. Thank you very much.
Yeah, great point. And one of the ways that hospitals manage that usually is by using a discharge lounge. So as soon as a patient is identified as being appropriate for discharge, and they might be waiting for medication or waiting of confirmation of transport, that kind of thing, patients would usually be moved into a discharge lounge. I think, I don't know the site that you're referring to, but I can only presume that because of the pressures that site may have been under, maybe the discharge lounge was full, and so that's why the patient stayed in a bed. Hospital wards do generally move patients out of a bed. Sometimes if a patient is fit to sit, they'll go into a chair or they'll go into a discharge lounge. And I talked a bit at the beginning around wards managing above their baseline. So if they have 24 beds, usually they are managing in excess of that by 1 or 2 patients. So that is how they extend, I guess, the amount of capacity that they might have on each individual ward. But, you know, one of the things in the NHS is let's get patients home before lunchtime. They go home during the daylight, they get a chance to settle back into their own environment. But it's been, you know, as long as I've worked in the NHS, it's been a long-standing challenge to get patients seen in a morning ward round. You know, they might be waiting for blood results, they might be waiting for medication. But that it's one of the things we do actually monitor the kind of the pre-lunchtime discharge, and it's incredibly small numbers. So understanding what it is that changes that, you know, it basically is that kind of timely assessment and timely actions that hospital need to undertake. And through going back to our UEC improvement programme, there is a ward processes aspect to that programme of work to kind of bring forward some of those actions to understand how they might get patients home sooner.
Oh, please. Yeah, it was the county hospital, and there was 3 of them still left in the ward. There was a patient's ward where patients were talking to their loved ones and sitting in that room. Couldn't they have been put in that room or segregated the room so people could, you know, talk to their loved ones and be left there waiting for them to go home? Because I commented and she said, I've been waiting since this morning. And all 3 of them said, yeah, we've been waiting most of the day. And to me, that is waste of beds that could be put back into use. Thank you.
We could only agree on that one, thank you.
Okay, thank you. Councillor Wallins.
Thank you, Chair. I just got 2 questions in relation to this. It says on the report that the workforce risk is rated high. Why are skilled staff leaving faster than we can recruit them?
Yeah, interesting question, isn't it? I think working in healthcare is really challenging, and I guess if you work in an urgent care environment, you know, the turnover, I guess, of some of those staff groups is quite high. I think one of the things through our winter plan has been around how do we make sure that this isn't about the ICB particularly, but this is about each individual provider organisation, so that might be the community trust or it might be an acute trust, is have they got in place the right broader workforce support so that, you know, things like just really basic things like our staff getting their breaks in a timely way. Are they being asked to work extended hours beyond the end of their shift? You know, are they picking up additional shifts, you know, when it should actually be a day off for them? And they're the sorts of areas of focus and learning that we're picking up through our winter oversight group. What are the things that are going to make the lives of staff that are working in really pressurised environments better? So yeah, I don't have a direct answer, but it is very much a core focus of what we're doing through our oversight.
Thank you for that. And the other question is, talking about the 13 oversight pillars, have any management or administrative layers been removed to redirect funds to the frontline care?
Well, you probably know this, but there's quite a broad NHS reform programme that is being undertaken right now. So ICBs will be shrinking between, I think it depends where you are in the country, but it's kind of probably between like 35 to maybe 55%. So that work is underway. And also in our provider organisations, there's a corporate reduction programme that ultimately is taking out some of those posts. But it's very much kind of in the infancy stages. But I guess, you know, I can't sit here and say that money's gone from one place to the other, but I can confirm that there are programmes to reduce workforce in corporate functions.
Okay, thank you, Councillor Wallins. Councillor Luca.
Good afternoon and thank you for your report. Going back to what you said before about handover, so when you first come into the door to when you actually go through the system and you're now actually at the exit point, discharge lounges. Now, being actually, and I obviously crew in ambulances, I actually see on a regular basis where people are sitting in the, discharge lounge for hours upon end because stuff like their care plans aren't in position, their medication hasn't been sent down, or they should actually have a respect form and there's no respect form. What are we actually doing? Because obviously that ties up the ambulance on the other side, not just actually on getting them in the door, but it also ties us up when it comes to actually getting out the door. To give you an idea, the other day, I sat on a job for 5 hours and 45 minutes waiting for a care package to be put in place. Obviously, once that was in place, then I could actually accept the patient and move them. What are we doing on that side to make sure that incidents like that are not being overlooked on a regular basis?
Yeah, I think some of those things that you refer to are probably hidden delays, aren't they? Because I think the emergency ambulance side of things, the information is very transparent for us all to see. But I think from a discharge, what we would term as non-emergency patient transport services, yeah, I think those individual examples are kind of very much within the acute setting often. Through the winter plan, we have put additional resource in to non-emergency patient transport, and we do flex that. You know, if we're having a very high discharge day and we know that the transport provider won't be able to address that, then we would flex that capacity again to make sure that we could get those patients home. But I think the process side that you're referring to, I think it's something that we do need to put more focus on, and we do need to understand what is influencing some of those delays, because it's not acceptable, is it, for an excess of a 5-hour delay around some documentation or an assessment that needs to be undertaken. So I think that does fall into the hospital process improvement work, but I'll separately pick that up if that's okay, because I think it's a really important point. Thank you.
Thank you, Councillor Luca. Any follow-up? Councillor Luca? No? Okay. Councillor Johnson.
Thank you, Chair. Apologies for my perceived impatience. My two main questions, what have now been asked, as quite often happens, they were relating to the blockages within the system and to the integrated neighbourhood care offer. And I very much like the idea of the mobile X-ray car. Very much reminds me of my days in my mining career when the X-ray van used to turn up at the pit top and you could get a free X-ray, but never mind. Those days are long gone. A more general question. Do you foresee any major viruses or mutations of viruses on the agenda for this year, regarding, particularly around respiratory illnesses? That was just something that I came up with because the other two questions have already been answered.
So this is, the viruses are it's UK HSA, UK HSA organisation that monitor the viruses, and we look at it, on a sort of weekly basis. We get public health information, and we haven't seen anything that is strange that's coming very different. Because we model ourselves on, and we look to see what's happened in the southern hemisphere. And that kind of leads us to some information to understand, well, what will happen in the northern hemisphere, because we tend to follow them with our respiratory illnesses. So you can never say never, because who could have predicted what happened with the global pandemic? But for me, what I'd say is what we're doing and how we watch things. There's nothing we're seeing that's going into your modelling that's saying, crikey, this is really going to be scary. It is the flu. But I think one of the things to pick up is if they come all together. That's been some of the issues in the past year when you've got flu, COVID, neurovirus and the respiratory RSV viruses. It causes a real problem in the hospital. And then with the blockages and quite some significant illness for people as well. So it's all that. So that is monitored, and I'm sure your public health colleagues would be more than happy to share that sort of data.
Okay, thank you. Councillor Hood.
Thank you, Chairman. Quite a lot of what I was going to say has already been said. But Tracy, I wonder, as an aside to what I'm going to ask, when you do your fall campaign, could you try not to make it ageist? I notice all the time that Fred's had a fall because he's over 60, but young Freddie fell over. Drives me nuts. But anyway, thank you for that. My concerns are that the surge plan is wholly reliant on the availability of the workforce. And we've already talked about the not possible cuts, the cuts that there are going to be made, which, well, it's just heartbreaking. We have discussed it in committee and there was a lot of very strong feeling. As Tracy will tell you, there was a lot of very strong feeling about it. So you're going to have a number of absences due to winter sickness, because it's not just your patients that get this, it's your staff that get it as well. And I was concerned when I read 2.1.3, and it spoke about the VCSE offers which are available to patients, and that they are utilised and maximised. Well, we all know that the voluntary sector is really, really struggling to get volunteers. In fact, Nottingham-Trent University this year did a survey and found that 44% of charities are not able to supply the requests for the demand of help that you need. So I'm just wondering, it sounds rather jolly, doesn't it, that you can partially rely on the volunteer sector, but each month that we go on, fewer and fewer people are volunteering, and those sectors are beginning to fall down. So I'm just wondering how you're going to face that. Thank you, Chairman.
So thank you. There's the bit on the workforce and sickness, and obviously you'll look at that in the modelling, and I'll let them pick that up. We have what's known as the VCSE Alliance, that is part of the Integrated Care Board, where we work closely with Support Staffordshire and VAST in Stoke to actually understand and work with the sector in a better way. You know, so we don't just roll over grants that have been going on for years. We actually work with the sector and look at what do we need to do and how can we work better with the sector, because I think there is learning from us, that there are better things we can do when we work with the VCSE sector, which actually can help them. You know, they've got money going from year to year and can help them with recruitment and all that. So there's quite a lot going on with the VCSE sector. Still a lot to do, but do recognise, you know, that we are working with people who are giving their own time. But actually there's some really great achievements. You know, when we look across the sector, there's just some massive things that are delivered from the sector. If I look across Staffordshire and Stoke-on-Trent, and obviously from yourself, is it's really brilliant what people see. You know, if you go to Port Vale, I know it's in Stoke, or you go to Burton Albion, some massive things that are being achieved just through the volunteering and the sector. So it is something that we have got here as part of our work going forward, but we need to be more strategic how we work with the sector, so we are taking that on board. Do you want to pick up work?
Yeah, just on the management of sickness, I mean, it is obviously a real challenge, and it has been for some time. But I guess as part of our modelling, we do sadly have to assume a certain level of workforce sickness, and of course that increases over the winter period as our workforce are exposed to some of those infections in their working environment. And there are some kind of operational principles that are deployed to make sure that things, the critical services can be covered. So, you know, kind of over rostering on, you know, on kind of some of the core shifts where we know that, you know, the service is going to fall over if there's no staff to run it. Redeployment of staff, so sometimes that's around standing down, other activities. So, you know, sadly, sometimes that's training, but it's all about how we maintain that quality and safety. That has to be the most kind of paramount area of focus for us through that winter period. And then, you know, in extremis, of course, it is cancellation of planned activity. You know, and we do see that. We have made a commitment in our winter plan. You'll see that in our paper that we do maintain elective services throughout winter. And I think to a certain degree we've protected ourselves to be able to do more of that by the establishment of more facilities at the county hospital site. But there will be a reality that, you know, if we need to redeploy staff from those areas to cope with emergency situations, then of course we would have to do that.
Okay, thank you. Councillor Edgeler.
Thank you very much, Chairman, and thank you for your report. It's very interesting. Please correct me if I'm wrong, but I think there's a doctor strike, a junior doctor strike that's imminent, and I wondered what effect this will have on your plans. And the other question is really, knowing that you have to save 360 million, what impact will that have on your plans that you've got? Will that create problems for you? Thank you. Thank you.
Yeah. So, yeah, you're absolutely right around the industrial action period that we're currently kind of getting ready for in terms of planning around that. I think it's an area that we're well versed in operating within, though. There've been, I can't remember the exact number now, but there have been a big number of periods of industrial action by the resident doctors, you know, previously the junior doctor cohorts. And I guess through that time, what we see is that the consultant body kind of step out of their usual role, and they obviously kind of manage patients so that critical services can be maintained. But we each time we have a period of industrial action, we develop a new plan and just make sure that we can maintain critical services during that time. What was the second one? Sorry.
Was that about the 306 million? So
Oh,
it's
yeah,
about the protected money in winter.
Yeah. Interesting point. However, I think when it comes to the management of winter, you know, we absolutely have to assure ourselves as a health and care community that we can cope with the demands that are coming through the door. Now, that won't always mean we meet constitutional standards, which, you know, is obviously our ambition, but how we maintain quality and safety through that period is really important. So the winter funding that we have allocated is unchanged at this point in time. So our plan is predicated on spending the allocation essentially. And as far as we know at this point, there is no intention to change that.
Councillor Doherty.
It's okay, my question's been answered already, thank you.
Councillor Kelly.
So it's been brought up today. I know it's in the work plan for January, but I'm just wondering what effect pharmacy delays have on you for getting patients out of the hospital and how many patients are waiting and how long are they waiting for the pharmacy to give their medication before they can leave. As well as that, you brought up earlier appropriate care in the appropriate place. My experience recently has been where I rang the GP, they said go to the Hayward, went to the Hayward, they said you need to be seen by a doctor. Go to A&E, go to A&E, they said you need to get triaged, wait. This is over 6 hours, by the way. Then I got sent to GP out of hours. There are no GPs in GP out of hours. You have to be seen by a nurse practitioner who again said you need to be seen by a doctor. It was only after 6 hours of spending time in the hospital that we were then sent to the Children's Assessment Unit to again wait a further 3 hours. If we were sent to the right place at the right time, that would have saved the hospital 6 hours of time of being moved from A to B to C to D.
So the first point just around pharmacy delays, that would be data that would be held within the provider. So I'm not able to answer that, but I can go to the provider and ask them if they've got a summary of the time that would be lost associated with that. In my experience, though, it's usually patients not waiting for just one thing. So we might have a report that says patients waiting for their medication to be discharged, but it's usually other things as well. But we're happy to look into that. Then just in relation to your experience, I think it's really difficult to comment. I agree, in principle, I absolutely agree with you. I think if you could get to the right place first time, it would reduce your experience, you'd receive the care faster, and it wouldn't waste resources as you describe it, kind of going around the system. But I think it would need more of an investigation to understand, you know, kind of why you were sent, where you went to, if that makes sense.
That's fine. It wasn't just me. This was going through every single person within the ward, every single person in the assessment unit was saying that they had a similar experience where they were sent to the wrong place and then they ended up there after hours and hours and hours, where they were being sent all over the hospital before getting the care that they needed.
Yeah, I think you've heard what Hayley said, is the ambition is to get to the right care at the right time. And that's to be the same for all of us. There will be times, even when some of the most expert navigators of the NHS, we may still sometimes struggle. But we need to learn from that, don't we? And you're quite right. It's a bit like the question about giving your information time and time again. That's where we can cut down a lot of inefficiency in the NHS. So it's a point well made, and it's something that is part of the plan, not just the winter plan. That's part of the plan for the NHS.
Okay, there is 3 more people that want to ask a question. If we could keep it short and to the point. We are running out of time now, so I do apologise, but the next councillor is Councillor Luca.
Hey, my question is, obviously, with the 306 million, in your own report, it stated it's going to affect 1,100 positions, and most of them are going to be bank and agency, which you actually stated. Now, obviously, with the winter plan, when we bring these savings in, as you want to call them savings, I mean, me personally, I'd call them cuts, because it says 1,100 positions. I mean, how are you actually going to make sure, if you've got staff going off sick, that you've actually got the necessary backup staff there to cover the shortfall?
Happy to pick that up in general, because I think we're going to be doing all things finance at our next meeting on the 1st of December, which will pick up the very specifics. But it would be a bit crazy for us to say, right, we need extra staff in winter, so we'll get rid of our bank staff, because then it'll cost us 10 times more to go to agency. So there is a balance of making sure that we have got enough bank staff, and bank is preferable, you know, and we do, you know, I've worked on the bank, and I probably will work on the bank again. But an agency does come at a premium, and you need to avoid that, because that actually is the same staff but for a lot of money more, and you don't want to be doing that. So there's a whole thing around the workforce that no doubt we'll address on the 1st of December. But certainly in terms of the winter plan, yes, we know we will need to have staff that will be able to be mobile, and like I think Hayley said, also we'll have to remove people from different areas. So it is a point well made, and understand, but I think we're looking at what's the best efficient way that we employ temporary staff in, and that has to be bank rather than agency.
The reason why I asked is because in the report that you've actually brought to this committee in the past, you stated bank and agency, that you were looking at actually cutting the use of them.
Chair, do you want me to just do a quick answer? I know we're coming back on that. So any temporary staffing is excess cost. Okay, so it's excess cost. So if you can actually keep people at work and they're happy and they're not leaving work and everything else like that, you're not getting that excess cost. So that's probably why it's so broadly stated in there. But there's a lot of nuances within that, and more than happy for us to go into that in deeper.
Thank you. Councillor Brown.
Thanks very much, Chair. Thank you to everybody. I realise it's a long morning now. I just want to bring up something which you might want to feed back to me about, and the rest of the committee. The X-ray car. Obviously, this is dynamic, fantastic approach. I can see this could go into care homes where someone's fallen. They've got a fractured neck of femur. The only problem with fractured neck of femurs in elderly patients, they'll be sunk in the bed. You might actually not be able to get the optimum quality of X-ray to be reported on. It's not just a single view. You have to have two views 90 degrees to each other. So my questions are around, if you come back to me on it, is firstly, it would be fantastic if it's a digital of suitable quality. I'd be really interested to know if the Royal College of Radiologists or the Society of Radiographers have accepted the quality of the Portsmouth study. And I think also it'd be really good to come to the committee how you're going to use it. Are you also going to take it to a 111, going to send them to, you know, sort of main centres in our towns to keep away from the hospitals? And obviously there's got to have proper safe operating procedures for patients which are fractured to go on. So I know there's an awful lot. I think it'd be really great for us to hear what's going on, but they must be of the correct quality, and on the machines that I can imagine, you can't cut costs on them, otherwise the substandard quality of X-ray will mean that the patient will not get the care and attention they need at their point. Thank you very much.
Quickly come back on that. Of course, we wouldn't be implementing anything that isn't actually quality tested. And like Hayley did say, it has been tested in Portsmouth. I haven't got all the details of who said this is good, this is whatever. But obviously there'll be a radiologist that's in the car that is doing the work, that will know the expertise that is required within. That's what you said, isn't it? Radiographer, not radiologist.
It won't be a radiologist. No, exactly. That's all right then. But I do think even a test in Portsmouth, I do think we need to analyse. Thank you very much.
Okay, thank you. Last question then to Councillor Beardmore.
Thank you. My question's only very brief. On your opening statement, you said there was additional capacity for Cheadle Hospital. I just wondered if you could explain to me what that was. That's my area, so I'd just like to know what's going on really.
Yeah, so I can take that one. So essentially what we do is utilise a ward on Cheadle Hospital for what's called the discharge to assess cohort of patients. So there are, I believe, 30 beds that we open at Cheadle. It essentially means we can get patients out of hospital that are only in hospital awaiting assessment for their discharge. So it's part of the kind of wider pathway. But that gets open normally December for probably 4 or 5 months. So it's 30 beds on Cheadle Hospital for the D2A pathway.
Okay, thank you for that. Thank you everyone for your questions. Me for myself have gleaned a lot from these meetings, these 2 meetings that we've had today. And I personally, Zach's probably going to kill me after this, I personally would like to call for a meeting about Staffordshire, the county hospital. As it's underutilised, it's something that really should be looked into. And with all the overflow and the struggles of the ambulances and everything I've heard today, I think it's something that we really should look into and at least discuss, if that's okay with yourselves. Can I just ask everybody to show of hands if they agree with me on that? Is that okay? Thank you. Would be added to as a separate meeting? If that's okay. Yes, thank you for that. So now, thank you for giving your information in your reports. I do appreciate you coming along. Our next on the agenda is for the District and Borough Update Report. Can I take that as read? Yep. Okay, so we're moving on now to, I'd like to pass you over to Zach because we're moving on to the work programme.
Oh, I didn't hear you going past the reports, because just say quickly on the Lichfield District Council report there, I'm still getting information on the very long awaited health centre that we've been promised in Borough for some time. And discovered recently that the County Council, for some time now, has not understood that Sport England would never agree to getting rid of playing fields without some sort of replacement. So that's something to follow through, which is, I find astonishing that the county should not have known about that before your time, don't worry. And this is some planning thing, but we'll report back on that at a later stage. Thank you. Thank you, Chair.
Thank you very much. Councillor Johnson?
I've got one or two updates, but would it be better if I emailed them to Zach? I've got them here, so I'll email them to you. It'll save time and obviously progress the meeting then.
Okay, thank you. So I'll just pass you over to Zach then for the report. Okay, sorry, it's on my paperwork, it says a report for the work programme.
Thank you, Chair. Yeah, so yeah, I think it's just pretty much taking it as read as it within the report. There is appendix, there is the executive response that the committee requested to receive in relation to the choice policy, which the request for committee is to note. And then I note that the previous item, the added item to do with County Hospital as well, to be factored into this as well.
Thank you, Zach.
I'd like to request another item to be added to the work programme. I don't know if anyone saw the news today. The Royal Stoke Hospital has been found neglectful after a baby has died due to gross failure of care. I would like to add to the work programme a report on the high-risk maternity services at Royal Stoke.
I'd just suggest it might be worth just trying to understand what the issue is. We can do that outside of committee, and then the committee can see what the strategic item would be to bring to committee, just so that we know what exactly is going on.
It's just gone through a full, that is after the inquiry, there has been an inquiry on it.
Okay, what I'm saying is we can pick it up after committee.
I will arrange a meeting, if that's okay, Councillor Kelly, and then we'll discuss from there. Councillor Luca.
Yeah, can I just say, from losing a child through medical neglect, I can understand your point, but what we have to realise here, there's a lot of differing circumstances that leads to that point. So I would actually strongly suggest that until we have all the facts, we don't make assumptions.
Okay, can we take this to another meeting? Thank you. So we're going to talk about Councillor Wallings.
Yeah, just thank you, Chair. It's just a very quick one. I know I keep mentioning about this, but is there any news in relation to the public consultation on the maternity unit?
Yes, so we are waiting a date when it's going to come, when it would be most appropriate for it to come to committee. Our understanding is it's not quite gone through the process yet. They're still doing the decision-making business case. So when we know, it'll go on to the work programme.
Okay, thank you, and thank you for everyone for coming. And today we're now going to close the meeting at 10 past. Okay, 10 past 1. Thank you all for coming, and thank you for all your questions.